We are live.
A very good evening, everyone. Here we are again by All India Ophthalmological Society for AIOS GuruSangam, Session 6 on cornea. I would like to thank the office bearers, Dr. Partha Biswas, Dr. Santosh Unawar, Dr. Manoj San Mathur, and all the scientific committee members for giving this opportunity for this session. Our expert panel include Dr. Merle Fernandez from LV Prasad Eye Institute, Hyderabad, Dr. Rama Rajgopal from Shankar Netralaya, Chennai, Dr. Revati Rajaraman from Arvind Eye Care Hospital, Coimbatore, Dr. Shrikant Sahu from LV Prasad Eye Institute, Bhubaneswar, and Dr. Vikas Mittal from LG Eye Institute, Ambala. We have with us very esteemed faculty of speakers, Dr. Tarun Sood from Indira Gandhi Medical College, Shimla, Dr. K. Kalyavani from Vinayaka Mission Medical College, Karaikal, Dr. Sarita Agarwal from Santosh Medical College, Ghaziabad, Dr. John Sarkar from Eye Care Institute of Medical Sciences, Haldia, and Dr. Avdesh Oli from Command Hospital, Bangalore. I welcome all the expert panel and speakers to this session. This is going to be the sequence of speakers with their topics and the time frame. I would request all the speakers to please stick to the time for adequate discussion thereafter. And with me, I have Dr. Rolika Bansal to co-moderate from Mahatma Gandhi Medical College, Jaipur. So with this, I move on to the first speaker for the day, Dr. Tarun Sood, who's going to speak on HSV keratitis. Dr. Tarun Sood, please.
I hope I'm audible.
Yes.
So first, at the very outset, I would like to thank.
Can you please do a slideshow?
um,
Doctor, the bottom play button, please. The red button, bottom the bottom.
which one?
The next to the percentage sign, the red button, the play button at the bottom.
I think I'll have to exit. This is not the
No,
one.
you don't have to exit on the screen itself. The PowerPoint show you have 59%. Next to that is a icon, and next to that is a red icon which has play button on it.
Somehow it is not showing to me.
You can stop and show, or you on the top. Can you see a slideshow written
Uh,
above the A, the darkest A?
no, this is not even showing.
You
So
can stop
maybe
and reshare,
Tarun,
please.
yeah, stop and reshare, or you can just speak from here itself.
I've stopped it. You can reshare, please.
Okay. It is showing me someone else is sharing.
No, you are sharing, doctor. Nobody else is sharing. You can just share now, please.
I have to click the screen and then my PPT, right?
You can just click on the share button on the Zoom screen, sir.
Okay. So is this fine?
Just waiting for it to come, sir. Yes, all good. You can start, sir.
Okay, so at the very outset, I would like to thank AOS team, GuruSangam team, for choosing me to present on this topic, HSV keratitis. Also, I would like to extend my thanks to the esteemed faculty present today. So I would just start with a brief insight into the uh, incidence patterns and the prevalence patterns. So
Dr. Tarun, you are not audible.
ma'am, my screen is, I mean,
Yeah, it's showing. It's showing. You
but
may.
it was showing to me actually. Just
Okay.
give me a minute. I'm actually not able to see my PowerPoint. I'm just able to see the names of the
Okay,
participants.
this is the screen which shows distribution of HSV keratitis types. So maybe you can just, keep moving and
Doctor,
keep.
you can click on the screen and you should be able to move. Just click on the screen where what you see. Now you should be able to move.
It is coming again and again to the.
Just click on the screen, sir. You should be good to go. Just click on the screen and move the arrows. You should be able to move it.
Can AV team can change his
We can move, Doctor. We can move to the next speaker till the
Yes,
time this issue is resolved.
maybe Dr. Tarun, you may stop sharing and we move on to the next speaker till you figure it out how we go about it. So next we go on to Dr. K. Kalavani. She would speak on microbiological investigations in corneal ulcer.
Yes, madam, I'm ready. I'll
Right.
submit
Okay.
on the
Thank you,
drive.
ma'am. Yeah, you may share your screen.
Yes.
Sure.
Ma'am, we can't hear you. I think you're muted. So, or maybe we can see your slides, but we
Ma'am,
cannot
you
hear
unmute
you.
yourself, please.
Dr. Kalavani, you can continue, please. Hello. No, you are not audible. You were audible before. I think you've added something.
Kalavani ma'am, your audio is not
If
connected,
you can just remove that
so
and
it's
continue.
not showing.
Yes.
Yeah, you are audible now, please.
Maybe you can
Yeah,
disconnect
you're
the
audible
speaker
now.
and
Yes,
it will
yes.
Yeah,
be
you
fine.
can just speak like that.
Yes, yes. Can you slide here? Right on. Laptop. Yes. Good evening, one and all. First of all, I thank. Am I audible?
Yes, ma'am.
Yes, madam. Good evening, one and all. First of all, I thank AIOS for giving me this opportunity. My topic for a discussion today is microbiological investigations in corneal ulcer. So let me start with the introduction. Corneal ulcer is an ocular emergency and one of the major causes of world blindness next to cataract and glaucoma. And microbial keratitis remains the leading cause of corneal blindness in the developing countries. According to the recent studies, in India, the annual incidence of infectious keratitis ranges between 11 to 799 per lakh population. The microbiological investigations help not only in making the accurate diagnosis, but also in the modification of therapy in cases of non-improvement with the initial treatment. According to the American Academy of Ophthalmology, smear examination and culture is advisable if the corneal ulcer size is more than 2 mm and if it is centrally placed, or if the ulcer is having a significant stromal melting, or if the ulcer present with a multiple diffuse stromal infiltration. In cases of atypical presentation suggestive of fungal or protozoal infections also, we need to do smear examination and culture. Now, what are the samples to be collected? Eyelid swab, conjunctival swab, corneal scrapings, and corneal biopsy only in case of selected cases. So, when we face difficulty in collecting the samples, so if the ulcer is very small and non-suppurative, the material may not be sufficient for us to test. In cases of advanced corneal ulcer with a decimatocele also, it is impossible for us to collect the samples. In cases with the deep stromal involvement with the intact epithelium, we have to go for the biopsy with the ileoid trephining. Now, for doing the corneal scraping, normally we use the Chimeras spatula. 26 gauge needle, Parker blade, platinum spatula can also be used. Collection of the specimen is usually done under topical anesthesia. For this, we have to instill a drop of 0.5% proparacaine. Proparacaine is superior to xylocaine because it is less bactericidal. And in cases of children and uncooperative patients, we may collect the sample under sedation. So once the material is collected, it has to be placed on 2 glass slides, one for gram staining and another one for KOH. And we have to put it in the 2 culture media normally. So one blood agar and another one is the Sabrot's dextrose agar. Suppose if we suspect any protozoa or parasitic infection, then we have to go for the specific strains and suitable media. So these are the common strains we use. The gram staining, it is best for bacteria. It can also be used to visualize the fungus and acanthamoeba. Genesa stain it always picks up the intracellular inclusion bodies. So it is very suitable for chlamydia infections. And Zeal-Neeson acid-fast strain is best for Mycobacterium and Nocardia, which is a partially acid-fast bacteria. Calcofluor white strain is best for acanthamoeba. It can pick up both cyst and trophozoite form of acanthamoeba, but we can visualize microsporidia, bacteria and fungi also. And acanthamoeba and fungi can also be visualized by the periodic acid shift strain. Now, first we have to do the gram staining. This is to differentiate the gram positive and the gram negative organisms. So first we have to fix the slide by heat fixation. Then we will put the crystal violet. Then you rinse it with the water, add iodine and decolorize it with the acid alcohol. Then counter stain with the carbol fusion. If the organism is gram positive, it will withstand the violet color. And if the organism is gram negative, it will be counterstained by the carbol fusion and appear pink in color. This gram staining sensitivity is 60 to 80% and specificity will be 98%. Then comes the Genesa stain. Genesa stain, here how to do is the smears are air fixed with the methanol and then stained with the Genesa solution. Genesa usually stains the DNA of the human cells as well as the cytoplasmic RNA. Genesa stain helps to differentiate the bacteria from fungus. It very well pick up the intracytoplasmic inclusion bodies. So this is a picture showing the cytoplasmic inclusion body in case of chlamydial infections. And this lower picture shows the trophozoite form of acanthamoeba with a pseudopod-like appearance. Then comes the acid-fast Zeal-Neeson staining. So the principle here is the mycolic acid present in the cell wall of the Mycobacterium stains with the carbol fusion and it resists decolorization by acid alcohol. So Mycobacteria being acid fast, it will take up the color of the carbol fusion and appear red in color against a blue background. Nocardia being partially acid fast, it will appear pink in color and beaded bacilli. Non-acid fast bacteria will take up the methylene blue color and appear blue. Then comes the calcofluor white stain. Calcofluor white stain, to the smear, we have to add a drop of calcofluor white with the Evans blue solution and should be examined under the fluorescent microscope. This calcofluor white binds to the cell wall, that is chitin and cellulose present in the cell wall, and it stains the organism. This helps in the rapid diagnosis of acanthamoeba. The cyst will appear as either blue or green color, depending on the filter used. It will appear as a double-walled cyst. And trophozoite will be reddish-orange in color, and it will be seen as a motile organism. Then the common thing used is the KOH. This is to differentiate the fungus. So the principle here is the KOH digests the chitin and cellulose present in the cell wall, exposing the fungal filaments. So to the smear or the specimen, we have to add a drop of KOH and then put a cover slip, examine under the microscope. This is a traditional and simple method to find out the fungal and nocardial filaments. It highlights the acanthamoeba cyst also. Here the sensitivity is 92% and specificity is 96%. Now the culture media which we commonly used is the blood agar and chocolate agar. Blood agar, chocolate agar both can be used to culture aerobic, facultative and anaerobic bacteria. The common bacteria like Pseudomonas aeruginosa, Staphylococcus aureus, Staphylococcus epidermidis and Pneumococcus can be grown well in the blood agar. And chocolate agar also picks up all the aerobic and anaerobic bacteria, but it is more specific for Haemophilus influenza. And for Neisseria gonorrhoeae, it's better to use Thiomartin agar medium. And thioglycolate broth is for the anaerobic bacterium. Suppose if we suspect a Propionibacterium acne, then which is a commensal and opportunistic pathogen, we can select this thioglycolate broth. Then Sabro's dextrose agar is for fungal culture. And for Acanthamoeba, the medium of choice is non-nutrient agar with the E. coli overlay. And LJ medium is for the Mycobacterium species. So this is the slide showing the various culture plates. This is a chocolate agar plate, and this is the nutrient agar. This is the blood agar plate, potato dextrose agar, and this is Sabro's dextrose agar. Now the procedure of doing the culture is, you have to collect the material. So apply the topical anesthetics, that is 0.5% proparacaine. Then scrape the margin as well as the base of the ulcer with a Kimura spatula. Then it has to be translated to the culture plate by making series of streaks. So once one quadrant you have to apply first, then every time when you go to the other quadrant, this spatula has to be sterilized by the heat. So the blood agar plate has to be turned to 90 degree, and then you have to make another few streaks in the next quadrant. Then again turn the plate to 90 degree, then make the streaks in the third quadrant. And lastly, you have to turn the plate to 45 degree and make C streaks in the fourth quadrant. So likewise, you have to make series of streaks, either parallel lines or you can make a C streak also. If we use a liquid medium, then the spatula has to be immersed directly into the culture fluid. Then all the plates have to be examined daily under the microscope. The duration of the culture, usually it takes 48 to 72 hours for the colonies to appear. And if it is a liquid media, you have to look for the turbidity in the media. In aerobic cultures of corneal specimen, you have to wait for 7 days before declaring it as negative culture. Anaerobic organism, you have to wait for 14 days. And for Mycobacterium and fungi, we have to wait for 4 to 6 weeks before reporting as no growth. Now, negative cultures. If you get a negative culture, it does not rule out the corneal infection. It may be because of prior antibiotic therapy, insufficient material, or poor reporting. So when we get a negative culture, you have to withhold the antibiotic for 48 hours, then do repeat culture or corneal biopsy. When will you suspect contamination of the culture? Any growth along the streak is only microbiologically significant. If you see a growth away from the streak, then it's probably a contamination. Now, the PCR, that is polymerase chain reaction, it is the most suitable and rapid test for the ocular specimen because it amplifies even the tiny amounts of DNA and RNA from the sample, creating many copies of specific gene sequence. So by detecting this amplified gene material, PCR can rapidly identify the presence of organism, either bacteria, virus, or fungus. So the advantages, as I told you, it is a rapid test. The results are available within few hours. So we can start the treatment early. And it is a very high sensitive test also, and detects the organism which are difficult to grow in the lab, like Mycobacterium, Acanthamoeba. And it is in culture negative cases also, PCR helps us to arrive at the diagnosis. So far we have seen about the common lab, that is technical point of view we have seen. Now we will come to the individual species. First comes the bacteria. So this slide shows about the staphylococcal infection. Staphylococcal aureus is a gram-positive organism and it appears in clusters. This causes dense, white, well-demarcated stromal infiltration beneath the epithelial defect. And in the blood agar plate, it's a facultative anaerobe and it produces golden yellow colonies because of the staphyloxanthin pigment produced by the organism. So this Staphylococcus aureus may be present as a commensal in few people and it becomes a facultative opportunistic infection. Then the pneumococcus. Pneumococcal causes hypopion corneal ulcer. This is also a gram-positive cocci. It is a diplococcus, so appear in pairs and it is a lancet shaped. So as I told you, it causes a hypopion corneal ulcer, also called as ulcus serpens. So one edge will be progressing and other edge will be healing like a snake, it's ulcus serpens. And in the blood agar plate, it is alpha hemolytic, producing good colonies within 3 to 5 days. Alpha hemolytic means it causes partial hemolysis of RBCs around the colonies. So it produces a gray or green colonies in the blood agar. Then comes the Pseudomonas. Pseudomonas is a gram-negative organism. So it takes the counter strain. It appears the carbol-fusin color, pink color. And it's a rod, it's a bacillus. So it rod-shaped with the parallel sides and rounded edge. And clinically, it produces, Pseudomonas produces a soupy infiltration, yellowish green pus, and it is adherent to the ulcer bed. And not nutrient agar, it produces opaque colonies. And in the blood agar, it causes large colonies spreading with the serrated edges with the metallic sheen. So it is a beaten copper appearance. So this is a colony of Pseudomonas aeruginosa. But some species may produce a blue-green pigment called pyocyanin. So the colonies may appear iridescent. And colonies will have a typical fruity odor. So beaten branch copper appearance is in Pseudomonas aeruginosa. Then comes in the bacteria Nocardia ceres. This is a weakly gram-positive and partially acid-fast bacillus. It will appear as a beaded branching filament. And the Nocardia produces superficial, multiple yellowish white pinhead wreath-like lesions. So it may be mistaken for fungal keratitis. In the blood agar, Nocardia colonies appear as a dry, chalky white odor. So it resembles a cotton candy. We can see the filaments or the mycelium protruding from the surface of the colony, which is a key feature of Nocardia. It's a slow-growing colony. It takes about 5 days to appear, but sometimes may take 14 days also. So you have to wait for 2 weeks before declaring it as negative. Then in the KOH mount, you can see a branching refractile filaments in the KOH under the microscope, and modified Gill-Nielsen staining will try to pick up the bacteria easily. It will appear as a pink colored branching filament because it is partially acid fast. So we can use the Gill-Nielsen stain. Now comes the fungus. Fungus can be visualized with any of these strains, gram staining, Ginza, KOH, or Calcoflar white. All have high percentage of positivity, and fungus is usually cultured in the Sabrot's dextrose agar or brain pot infusion agar. So this is a KOH picture showing the fungal filaments, and this is a gram staining showing the mycelium of the fungus. And Sabrot's dextrose agar is the universal medium to culture the fungus. If you add any antibacterial agent, it will enhance the fungal growth. Now, in India, tropical countries like India, these two are the common organisms causing fungal corneal ulcer, Fusarium and Aspergillus. Both are pigment producing fungus. And this Fusarium usually causes a superficial infiltration with the feathery edges. Aspergillus always has a deep infiltration, and the KOH shows a filamentous. You can see the mycelium with the hyphae, and Aspergillus will have the conidial heads. Then Fusarium colony in the potato dextrose agar, it always produces cottony colonies. So the mycelium extend upward from the surface of the growth medium. The color of the mycelium may vary from white to pink or purple color depending on the species, and the pigment of the colony increases with the age. Then this is a picture showing the Aspergillus colonies. Aspergillus colonies will appear as a powdery, fluffy or granular texture, and the color varies from white, green, brown or black, again depending on the species. The conidial heads give the colonies the characteristic color and texture. Then comes the Candida. Candida is not so common in India. It is more common in the temperate climates. It is a yeast-like fungus. So we can see the pseudo hyphae, and this reproduces by budding method. That means the daughter cells will appear on the surface of the parent, and once the daughter cell matures, it gets separated from the parent. So it reproduces by budding technology, and the Candida produces yellowish white, densely separative infiltrate, mimics like the bacterial keratitis. And this is a periodic acid sip stain showing the fungal spores. Then Candida can be very well grown in the Sabrots dextrose agar. Here the Candida colonies will appear circular or dome-shaped creamy white colonies with a moisture texture or glistening surface. It shows a rapid growth within 24 to 48 hours. Now comes the Acanthamoeba. Acanthamoeba is a free-living protozoan present in the brackish water or in the soil, and the characteristic clinical features of it produces radial perineuritis and ring infiltration. And this is a hematoxylin-eosin staining, which shows the characteristic double wall cyst of Acanthamoeba. And this is a Giemsa stain, which picks up the tropozoite with a pseudopod-like appearance. And this is a cauliflower white stain under the fluorescent microscope with a double-walled cyst. And this is a non-nutrient agar with the E. coli overlay, which shows the snail tracks left by the amoeba. These are all the snail tracks left by the amoeba. And these are confocal pictures, which shows both the tropozoite as well as the cyst. The tropozoite will be spindle-shaped with the pseudophodia, and the cyst will be double-walled, which can be very well seen with the confocal microscopy. Now comes the parasitic corneal ulcer, that is Pythium keratitis. Pythium keratitis is a rare but sight-threatening disease. It carries a high morbidity rate, and it resembles a fungal keratitis. It presents with a central dense grayish-white infiltration, and the characteristic finding is a tentacle. So the tentacle-like lesion is a characteristic of Pythium. And another important character in Pythium is it causes peripheral gutter. So here this picture shows a larger central dense infiltration, hypopion, and if you see carefully, there is thinning in the periphery of the cornea. So the gutter as well as the tentacle are the characteristic feature of Pythium keratitis. And Pythium in the KOH strain, the filaments will appear as a long, broad, ribbon-like filaments with a few septae only, because it is partially septate and it is a gram-positive organism. Then Pythium, when you see with the cauliflower white stain, it picks up the mycelium. So the stromal mycelium will appear as a irregularly branched, broad ribbon-like hyphae. It may take up either blue color or green color depending on the filter used. And if you see the Pythium colonies in blood agar, they are colorless colonies. Remember, 3 up here, flat colonies, feathery colonies with the filiform margins. So it produces colorless colony in the blood agar, and it takes about 3 to 5 days to appear for inoculation. So Pythium can be seen with any of the one. You can use the KOH, or you can use the cauliflower strain, or you can be cultured in the blood agar. Now coming to the viral keratitis, direct demonstration of the viral antigen or the products are possible by Giemsa staining, electron microscopy, enzyme immunoassay, and by PCR. Giemsa staining picks up the intracellular inclusion bodies. It will not pick up the virus. It will not stain the virus particles, but picks up only the inclusion bodies. And we can visualize the virus directly using the electron microscopy, either by negative staining or by thin sectioning method. And in enzyme immunoassay, this enzyme-coated antibodies, it binds to the viral antigen and it converts the colorless substrate into a colored product. So if there is a color change in the media, it indicates a positive result, and the intensity of the color is proportional to the amount of viral antigens. So electron microscopy pick up the viruses, immunoassay it will react with the viral antigens, and Giemsa picks up the inclusion bodies. PCR test will not pick up the viral antigen or viral product, but this will pick up the genetic material of the viruses. PCR is the best lab test. It's a highly sensitive and rapid test to arrive at the diagnosis of viral keratitis. The other investigations are corneal biopsy. This is indicated only in cases of deep ulcer or non-responsive ulcers. While taking the biopsy, use a trypsin, and we should include the margin of the healthy tissue also. And using the enzyme assay, it detects the matrix metalloproteinases 9 in the tears of patients with a severe corneal ulcer, and its presence indicates a rapid progression. Usually these patients, the ulcer will erode into the deeper layer, and perforation is more common if we see high levels of matrix metalloproteinases. And advanced technique is immunohistochemistry. This will be helpful in the diagnosis of autoimmune ulcer, that is the Moran's ulcer. Here, the inflammatory markers are picked up by the immunohistochemistry, that is CD68. And the recent studies have shown the higher ratio of CD4 to CD8 in the Moran's ulcer. Immunohistochemistry requires the tissue sampling, so it is reserved for the patients who are undergoing keratoplasty only. We can use the immunohistochemistry. Now the take-home message is microbiological workup has become an indispensable part of investigations in corneal ulcer patients. Proper sample collection is important, as well as meticulous reporting is the vital part of the workup. In resistant cases, use of specific strains and selective culture media is essential. Thank you.
Thank you, Dr. Kalavani. That was a very elaborate and a very extensive micro workup. I think we all need to understand the importance of a micro workup, before we start any kind of a treatment. I would like to have a question from Dr. Rama. Normally, lot of times when we in practice see a lot of patients, being treated by multiple antibiotics and antifungals and antivirals when they land up. So what would be your, for the benefit of the residents and people who are general ophthalmologists, what would be your get-to-go way to, start the treatment? Because already there is a case which has been treated with lots of things.
So I think that was an excellent presentation, Doctor. So I think
Thank
the
you.
first thing is to understand at what stage the patient is coming to you. Is the patient responding to the treatment or not, number one? Because only if a patient is not responding to the treatment, you may want to pursue a different line. So here the history becomes very important. What we always forget is we just look at the eye, we don't, and the clinical presentation, we really don't go back on the history. So history very important, steroid use, immunosuppression, contact lens use. These are certain things that are definitely going to give us a cue, and whether the patient has been compliant with the medication, is the diabetic status under control, is an underlying immune mediated disease. All these things are going to actually help us to understand whether the response to treatment is adequate or inadequate. So it will tell you what exactly is the reason for lack of response to treatment. This is the outer structure. The second point is, are we dealing with the right organism or not? Because many times what happens, you get one organism, you have a clinical diagnosis in mind, you get one organism, you just think it is the same organism and you start the treatment, but it may be a combination of organisms. It may be the patient is resistant because already has been using many medications from the past. So stop and think whether the patient's clinical findings and your microbiological findings are in tandem or not, because otherwise you're going to be lost about whether you're treating the patient on the right lines or not. This cocktail of medication is happening very frequently, especially in conditions like nocardia, or where unusual organisms, atypical mycobacteria, where really, or even pythium for that matter, people are not very familiar with these organisms. So you see patients with even a combination of bacterial, viral, fungal, and then you don't really know what you're dealing with. In these cases, if the ulcer is progressive and the patient is on medication, this is compliant, you have looked at all the systemic factor under control, sometimes it may be worthwhile giving a small drug holiday to see whether you can start the process afresh. Your thought process can start all over again. Once you give the drug holiday, the toxicity component is gone, then maybe it also helps you with a better yield of the medications.
Yeah, very correctly said. We can stop all the medications for like 24 hours and see and re-scrape it and look at the organism again and the drugs. Merle, I wanted to ask you a question that, how commonly do you see pythium in your practice, and what is your, how do you diagnose, or what could be the differentiating feature? Because it looks very much like, any other organism, though it could be very aggressive also and may land up with a keratoplasty. So how do you make a diagnosis?
So essentially, because it's a referral center, probably we may be seeing more pythium than others would see. Essentially, because people would have tried antifungals, realized that it's not responding to antifungals, and then send the patient across to us. But essentially, when you see a patient who presents to you with like Dr. Kalavani was mentioning, an infiltrate which looks like fungus. Essentially, the key features here would be very fine tentacles that you see, but it's best visualized on indirect illumination and on sclerotic scatter. If you see it with direct illumination, you may not be able to appreciate, but indirect retroillumination and sclerotic scatter will actually highlight the tentacles. Yeah. In addition, there'll be these dots that you can see. So there are tentacles and dots. Once the disease progresses, then it becomes plaque-like with a gutter. So those are the clinical clues that we look at, trying to kind of differentiate clinically from fungus. And then once you scrape, obviously when you scrape, you'll see these broad ribbon-like filaments which have got sparsely septate. They've got these vesicles within them. They have got ribbon-like, they fold. And so that's the clue that you have when you're doing this the smears. And then once you start them on topical medication, linezolid and azithromycin in very frequent doses, then you start seeing response there.
So do you think that most of these patients do need a keratoplasty, or they are
So I think whatever data we have seen so far, once we've started the appropriate management, so we had actually done a study some years ago where we looked at ulcers which were smaller in size. When they're less than 6 millimeters, about almost 80 to 90% of them would respond to medical management. But if they were larger ulcers, the percentage of response was obviously lesser. And we were resorting to doing PKs. But when you do a PK in Python, you have to keep in mind that the margin of clearance has to be 1.5 millimeters and beyond, because otherwise there's a tendency for recurrence. So so they do respond if you catch them early. The larger ulcers are the ones that we have a challenge with. And then we tend to notice the guttering. I think that's important to glue them at that point of time, because if you continue your medical management while they have the guttering and the thinning progresses, for some reason, and we don't know exactly what's going on, there is some collagenolysis happening in the peripheral cornea there, and that may lead to perforation. So you'll be surprised that the patient comes back to you with a perf, even though they were supposedly responding. But it's important to glue them at that point.
excellent? Actually, the take-home message is that we need to, micro workup is essential, as like Dr. Kalavani said, and it has to be very thorough. And we can have a small lab in the, as a side lab in our clinics and the hospitals. And it's mandatory to have a lab in the medical colleges also, because, that's where when you start to, start scraping and at least seeing Grams, Giemsa and KOH with calcofluor. Thank you, Dr.
Can I add
Kalavani,
one?
for it.
Thank you, ma'am.
Please, Dr.
Sorry. So just one point, I think, about the scraping, because there will be a lot of ophthalmology general practitioners. When you have very thin cornea with a desmetocele, you have to be very, very careful, especially if you're seeing a peripheral infiltration. Be very careful. There is a small but definite role for even conjunctival swab in some of these eyes, although we prefer to do the scraping because the yield is much better. The other place where you may want to be very careful with the scraping or do a swab is when you have a blebitis, because when you have a very large thin wall cystic bleb, you might perforate the bleb. So there again, maybe because quite often the infection is usually from the commensals, there's a small role for conjunctival swab in these eyes. But most of the times we prefer the scraping because the yield is better.
Absolutely, Dr. Rama. Thank you so much. So we move on to our, yes, Dr. Kalavani.
Thank you, ma'am.
Yeah. So we move on to our next speaker for today. Dr. Tarun, are you ready with your presentation?
Yes, ma'am. Am I audible, ma'am?
Yeah. So he's going to present on HSV keratitis. Yes, please.
So, sorry for the I hope I'm audible, and sorry for the interruption. So
Yes.
I'll be starting with the epidemiology of the HSV keratitis. Corneal blindness affects near 45 million. Again, my slide here.
Yeah, we can see your slide, Tarun.
They're just.
So what you can do is you can stop the slide share and just be on that.
Doctor, can you just click on the screen first? Just click on the screen and start moving the slides up and down if you can.
Okay. So, see, even I'm sharing.
No, you already shared. There, you see the introduction wala slide. Just click on the slide
Okay. So
and control with there. Yes, now you should be able to move the slide.
Okay, so corneal blindness, as we know, in this paper in Lancet by Flexman SR et al., corneal blindness affects near 45 million people worldwide, with 1.5 to 2 million new cases reported yearly. In another study in Survey Opthal, 2012, the HSV keratitis accounted for 40,000 new cases of visual impairment worldwide everywhere. Here, And this is a known fact that most of the recurrent diseases, it presents as epithelial dendritic keratitis. Necrotizing stromal keratitis is uncommon, but still it carries a high risk of perforation and permanent visual loss. If we look at the data which was collected by the biggest landmark study, that was the HEADS, and from a large cohorts, the epithelial keratitis amounts to near 50%, succeeded by the stromal keratitis, which constitutes both immune and necrotizing, and it amounts to near 25%. The endotheliitis constitutes to 10 to 15%, and neurotrophic keratopathy, it makes near 5 to 8%. There was a study by Patidar v. et al. In IGO, which calculated that HSV keratitis formed near 12.3% of the infectious keratitis. However, this is the biggest study by LVPI group, which included near 8308 patients and 8897 eyes. Again, the epithelial keratitis had the highest incidence, followed by stromal keratitis and then endothelial keratitis. They also concluded that most of the patients had a rural belonging. Now, the herpetic eye disease study, I'm just a single slide I'm taking on this, that this study, which was conducted from the late 1980s to 1990s, provided the guidance as to the role of the antiviral therapy and topical corticosteroid in the treatment and prophylaxis for the varied presentation of HSV keratitis. However, having said this, we all know that the patterns of clinical care often radically diverge from what is considered best practice. For what is written in literature might not come true in practice, and your practice and your standard guidelines might not apply to every case. You need to curtail your treatment details depending upon the case presentation. For a PG understanding, it is a human, HSV is a human, it belongs to human herpes virus family. It is a double-stranded DNA virus, and its size is approximately 150 to 200 nanometers. HSV1 is supposed to be causing orolabial involvement, while HSV2 causes genital involvement. Ocular disease is most probably due to HSV, except in the neonates, where due to intrapartal infection, it is caused by HSV2. It is also regarded as a neurotrophic virus because it has a particular affinity for sensory ganglion cells, such as trigeminal ganglion. And the humans are the only natural host. We can get it by direct contact with the lesion or the salivary droplets or the fomites. Children and adults with active disease are also the source of infection. However, the majority of the infection come from those people who harbor it and they are asymptomatic. And this is a double-stranded DNA. This is the icosahedral capsid. This is the enveloping tegument, and the viral surface has glycoproteins. So this is what I'm talking about. Whenever we get an infection, the organism, it goes back and retrogradely, and it resides in the trigeminal ganglion. And whenever you get a stress or maybe some surgery or maybe some ocular procedure, which is supposed to reactivate the disease, you get the ocular disease via the ophthalmic nerve. Now coming to pathogenesis, the pathogenesis is primary ocular infection. It leads to once the primary ocular infection is established, the virus is then retrogradely transported to the trigeminal ganglion, and when there it is establishing itself in a latent phase. And when there is an altered immunity by organ transplant or by HIV or maybe some local vectors such as refractive surgery, a YAG capsulotomy, contact lens usage, a penetrating keratoplasty, or maybe cataract surgery, or some topical medications, prostaglandin analogs or corticosteroids or UV exposure, trauma, stress, all of these are believed to cause some amount of reactivation and hence recurrence can happen. Now, this article by James Chodosh, in this article, he tries to lessen the confusion which is regarding the naming of the HSV keratitis. While the dendritic and geographic or deciform are more shapes and they are not the diagnosis, we should naming the lesion as dendritic or geographic, and it would be more simpler if we call them epithelial lesions. Similarly, necrotizing is a histopathological diagnosis. So you should be acquainted with the terms like stromal without ulceration or stromal with ulceration. And similarly, disc is a shape, and you should be using endothelial keratitis instead of naming the entity as deciform. Primary HSV infection is when the disease is caused by actively replicating virus. So it could present as congenital and neonatal herpes. It is, as I told in earlier slide, it is acquired when there is an intrapartal transmission, and it can present as periocular skin lesions, or there could be conjunctivitis, epithelial keratitis, or stromal keratitis. The maternal IgGs are supposed to confer the protection till 6 months of age. And it is believed that till 6 years of age, nearly 85% of the population is affected, whether symptomatically or asymptomatically. The in neonatal form, whenever the infection is contained within 2 days to 2 weeks, you presume it is to be due to primary HSV. And this kind of conjunctivitis is non-purulent. Even keratitis can take place and can occur. The rest of the forms of primary HSV infection are blepharoconjunctivitis, which can present as periocular and eyelid skin vesicles, the ulcerations and dendrites in the conjunctiva. Usually, these dendrites will heal without any scarring. There could also be a presentation as acute follicular conjunctivitis, which could be mistaken for adenoviral conjunctivitis, but adenoviral conjunctivitis will be bilateral and HSV is usually unilateral. Keratitis can also be present in 3 to 5% of the cases. There is a diffuse punctate epitheliopathy or a corneal vesicles, and this is bilateral in immunocompromised and topic. The epithelial keratitis, usually it presents as corneal vesicles or dendritic ulcers, which then coalesce to form a geographic ulcer and a marginal ulcer. The stromal keratitis has two predominant forms, immune and necrotizing stromal keratitis. Endothelial, for a broader description, is divided into disciform, diffuse, and linear. Coming to epithelial, epithelium is due to replication of live HSV in the corneal epithelium. Necrotizing stromal keratitis is again due to direct viral invasion of the stroma with severe immune reaction, but there is also immune component added to it, and there is tissue necrosis. Immune stromal keratitis is an entity which is primarily due to antigen antibody complement mediated type 3 and type 4 delayed hypersensitivity reactions. And in endothelitis, there is an immune reaction which involves the endothelium as well as sometimes AC, and possible role of live virus is also implicated in this. This is important because the treatment is actually based on what the pathogenesis is. So the epithelial lesion is the earliest lesion is a clear vesicle, which is minute raised vesicle in early stage, and this only coalesces to form dendritic or geographic ulcer. While the most common manifestation is dendritic, dendrite is a linear dichotomously branching lesion with terminal end bulbs, and the borders are raised, grayish, and swollen. These are the little vesicles. Most of the times we don't get to see these vesicles. The lesion which we get to see most commonly is a true dendrite, which will have a terminal end bulbs and the base will be staining brilliantly with the fluorescent blue because it has encroached onto the basement membrane. And these terminal end bulbs are supposed to contain the live virus. The pathogenesis is that once the HSV infects the corneal epithelial cell, there is a cell-to-cell spread of virus along the basal plexus of corneal nerves, leading to branching lesions. There is an actively replicating virus in the borders or the terminal bulbs, and the branches have a central epithelial decomposition bordered by punctate epithelial microdestruction. Sometimes you will not see these, sometimes you confuse these dendrites, which are not actually interconnecting, which do not have terminal buds, which are smaller in size, and which do not have central ulceration. So these are pseudodendrites. They are very common in herpes zoster. Again, they are also common when the epithelium is healing up, or when there is post-traumatic corneal abrasion, or recurrent corneal ulcer due to Cogan's dystrophy, or a contact lens wear. So both of the, even cornea verticillata, which is supposed to be drug induced, is again is a differential diagnosis. So this slide is just to tell that how the fluorescein, it stains the ulcer bed, and the rose bengal, it stains the virus laden margins at the margin of the ulcer. It is because rose bengal stains the cells which are devitalized, which are deepithelialized, and which are devoid of mucin, whereas fluorescein will be present whenever the basement membrane defect is present. So if you need to take a viral culture, then rose bengal staining is not to be performed because rose bengal is toxic to HSV and it will decrease the yield of the culture. And anyways, if you want to elicit this picture, you do a rose bengal first and then you do a fluorescein. The treatment of dendritic or geographic ulcer is same. It is topical or systemic antivirals for 10 to 21 days. Most of the times, some 95-99 times, it will get healed by topical ointments only. That is ointment acyclovir 3% 5 times a day, or a ganciclovir gel 0.15% 5 times a day. However, the cases in which you need oral antivirals, such as pediatric patients where immunity is high and they are not able to instill the drops 5 times a day. So it is more compliant that you give an oral antivirus, because immunity again in the pediatric patients is high. The ocular surface is poor because ganciclovir or even acyclovir to some extent is supposed to cause a damage to the ocular surface. If there is also in the prophylaxis prior to and post ocular surgery, such as you have to do a keratoplasty in HSV, or maybe a cataract surgery in cataract surgery in a patient who has a history of HSV, then you need to give these drugs as prophylaxis so that there is not a recurrence of epithelial disease. And the dose is, if you have to give them oral, in the oral form, acyclovir 400 mg 5 times a day, or valcyclovir 500 mg 3 times a day. This is called a geographic ulcer. This is due to progressive enlargement of dendritic ulcer. This is due to inadvertent use of topical steroids, immunocompromised patients, or long-standing untreated ulcers. If you see very carefully, the dendrites have merged and they have formed a geographic kind of pattern. And even these borders will contain the live virus. Now, next is what is neurotrophic or metahepatic ulcer. It is when the epithelium is not able to heal after dendritic or geographic ulcer. It is neither infectious nor immune. It is just that the corneal innervation has been impaired because of the virus, and there is a decreased tear production as well as chronic use of topical medication. So all these factors have led to the failure of the healing of the epithelium. And so you see a epithelial defect which is oval in shape, which is smooth, thickened border, and it has smooth and thickened border, and there is a heaved up epithelium. Again, grayish white opacification of stroma at the ulcer bed can be seen. So this is a very frequently seen diagram in which the geographic difference between geographic and metahepatic ulcer is seen. You see in the geographic ulcer, there is a large fluorescein staining epithelial defect and there are the bulbs, whereas in the metahepatic ulcer, the rose bengal staining of unhealthy epithelial cells occurs across the ulcer base and the fluorescein leaks into the stroma and the periphery. This is known as reverse staining, while what I told previously is known as inverse staining. So coming to marginal keratitis, this results from the active viral disease. The lesion is located close to the limbus, and if you look very carefully, even here there are dendrite-like projections which have coalesced. So if it is this is an infectious lesion and it responds well to antiviral treatment. The differential diagnosis remains the staph keratitis, but the staph keratitis usually occurs at the places where the lid makes in contact with the cornea, that is 2, 4, 8, and 10 o'clocks. Also, staph keratitis will not have so much of inflammation and there will be the presence of a lucid interval. Coming to the stromal disease in HSV, it accounts to 16% of the initial episodes of ocular HSV, and there's 15 to 28% chances of recurrence. The primary stromal environment, as I told, could be immune or necrotizing, and secondary could be a sequelae of infectious epithelial keratitis, neurotrophic keratopathy, or endothelitis. Now, what is immune stromal keratitis, or now what is, or maybe which we should better refer as stromal keratitis without ulceration? So it occurs in 20% patients with ocular HSV. It is due to retained viral antigens within stroma. These triggers antigen antibody complement cascade and further leading to intrastromal inflammation. So you see here there is a diffuse haze, stromal haze, more of cellularity and less of edema, which is characteristic of stromal keratitis. And the features are stromal inflammation with intact epithelium, which could be focal, multifocal, or diffuse, and the epithelium will stay intact in this. The chronic recurrent forms will lead to stromal scarring, thinning and neovascularization, and lipid deposition. Immune ring may be present, which is known as Wesley's immune ring. Stromal neovascularization, sectoral or diffuse, may be present. Coming to the treatment of the stromal keratitis, stromal keratitis without ulceration, you see more of cellularity, and this could be diffuse and this could be multifocal. You could also see the previous ghost scars. And the treatment is predecetate 8 to 10 times along with oral acyclovir 400 mg BD or valcyclovir 500 mg OD. That is a prophylactic dose, and taper it weekly dosing till the dosing reaches 4 times a day. It is important to remember that you have to taper it very slowly beyond 10 weeks, and then you can go to alternate or twice or once daily dose. There is no hurry to taper or to slow down the steroids. Do a very slow tapering, and at the time while you are continuing the steroids, you also have to continue the oral acyclovir simultaneously. Coming to again the role of the corneal sensation. So if the presentation is not dendritic, the testing for corneal sensation can help us reach a diagnosis, because every time the virus replicates in the trigeminal ganglion, it is going to kill some cells in which it is replicating, leading to hyposensitivity and further reduced corneal sensation. Though the reduced corneal sensation might not be evident in the first attack, but in subsequent attacks, invariably you are going to see it. And there are very few conditions which actually reduce corneal sensation. So this is a one test which we should not tend to forget, and it is to be done before applying an anesthetic agent so that there is no confounding. Coming to necrotizing, or which we should refer as stromal keratitis with ulceration, you see viral replication, pronounced host inflammatory response, which could lead to intrastromal inflammation leading to corneal thinning and perforation. And overlying, so here there is an corneal thinning and perforation and suppurative infiltrate along with the vascularization. In this case, since the oral virus, the role of virus is itself is implicated, so you give a therapeutic dose of oral acyclovir 800 mg 3 to 5 times per day for 7 to 10 days, or oral acyclovir 1 gram TDS. Topical antibiotics may be added for secondary prophylaxis. We have to be very careful while we are giving steroids. They have to be initially given in a low dose, and then once the epithelium heals up, or if you have sent a culture and the culture becomes negative, you can hike up the dose of the steroids. Again, oral acyclovir 400 mg 2 times a day to be maintained as long as topical steroid is continued. So this is the classification of HSV endothelitis. The first picture is diffuse. This is not actually exactly a proper description of diffuse, because it has a neurotrophic element also. So it's a mixed presentation. But these desmids fold throughout the cornea is a diffuse if there wouldn't have been this this epithelial defect. And deciform is there is a disc of edema and there are keratic precipitates beyond that disc of edema. And the linear is in which a linear line of KPs extends from the limbus to the center of the cornea, this in a serpentine manner. So inflammatory reaction at the level of the endothelium, first presence of KPs and then overlying stromal edema and the presence of AC cells in flare. This makes the diagnosis of endothelial keratitis, but the crux is that there should be no stromal infiltrates. There should be more stromal edema and less cellularity, because whenever endothelium is going to be affected, then stromal edema will be there. So if there is more of stromal edema, less of cellularity, there is a sharp demarcation line between the involved and uninvolved area. There is absence of stromal infiltration. There is presence of KPs. Then this is endothelitis. Sometimes the edema is so much of edema that you cannot see KPs. So by the time the disease starts resolving, you see some KPs, or maybe you need to do an ASOC to see those KPs. So coming to this is what I have to discuss in previous slide. The disc-shaped area of stromal edema in central or paracentral area leading to ground glass appearance is known as disciform. If there is diffuse stromal edema, it is diffuse, and if edema is between line of KPs and limbus, it is linear. What is the treatment? The treatment is oral acyclovir at 400 mg 3 to 5 times a day, valcyclovir 500 mg BD or famciclovir 200 mg BD along with topical steroids 6 to 8 times daily. And as you taper the steroids, you continue this treatment. And now coming to keratouveitis. Keratouveitis, again, there is role of active virus. You could see mutton fat KPs as well as it could present as non-granulomatous form. There could be sectoral iris atrophy and process-synechian cataract can be formed once it gets healed. Trabeculitis is due to clogging of the trabecular meshwork by the inflammatory cells. There is quick response to topical steroid and there is sudden IP elevation. The treatment of herpetic keratouveitis is oral antiviral in therapeutic dose for 2 weeks, topical steroid for 6 to 8 times a day, and anti-glaucoma for trabeculitis. HSV keratitis is primarily a clinical diagnosis, and most of the times you don't need to do any investigation. Still, if there's some confusion, a Gimsa stain can be done, which will show Cowdery type A inclusion bodies. Culture is the gold standard. The PCR can also be done, and the immunological tests such as ELISA can also be carried out. Now, where do you need prophylaxis in HSV keratitis? When there are more than 2 epithelial recurrences per year or any kind of stromal keratitis, post-keratoplasty, post-cataract surgery, post-YAG, post-PRK, post-LASIK. In the history of immunosuppression atopy, neurotrophic cornea with previous HSV, you will need to give immunosuppression in the prophylaxis. And the recommended regime is acyclovir 400 mg BD or valcyclovir 500 mg OD duration for more than 12 months, and may continue indefinitely in high-risk patients. So this is where I started initially, was the heads, and this is what was done in heads 1 and heads 2. So in next 2 slides, in heads 1, they had 3 trials. In HSV epithelial keratitis trial, they already put the patient on topical trifluridine for epithelial keratitis, and in group 1 they added oral acyclovir 400 mg 5 times a day. In group 2 they added placebo, and they found that there was no added advantage. In HSV acyclovir prevention trial, which in the patients who had past history of HSV keratitis within 1 year, in group 1 oral acyclovir 400 mg BD for 1 year was given, and in group 2 oral placebo was given. They found that addition of oral acyclovir prevented recurrences to the tune of 41% and more severity of keratitis to the tune of 50%. And in the last arm, they studied HSV risk factors, and they studied that a history of epithelial keratitis could be a risk factor. But in this study, they found that behavioral factors were not of much importance. This was the second study, HSV stromal keratitis, on patients on topical trifluridine but not on steroids. In group 1, topical 1% acetate was given, and in group 2, placebo was given. There was a faster resolution found with steroids. However, the final visual acuity was same. In another arm, the HSV stromal keratitis on topical trifluridine and prednisolone acetate 1%. In group 1, oral acyclovir 400 mg 5 times a day was given for 10 weeks, and in group 2 placebo. They found no benefit of oral acyclovir. And in HSV iridocyclitis patients on topical trifluridine and prednisolone acetate 1%. In group 1, oral acyclovir 400 mg 5 times a day was given for 10 weeks, and in group 2 placebo was given. They found that there was a decrease in treatment failure rate with oral acyclovir. So, in short, according to head study, were topical steroids helpful for stromal keratitis? Yes. Was acyclovir helpful in stromal keratitis? No. Was oral acyclovir helpful in HSV iritis? Yes. Does oral acyclovir prevent development of stromal keratitis and iritis in epithelial keratitis? No. Does oral acyclovir prophylaxis minimizes HSV recurrences? Yes. So, what can we take from heads for stromal keratitis without ulceration? That steroid therapy for 10 weeks is probably insufficient. You need to prolong your therapy beyond the 10 weeks, and tapering has to be very slowly. Like once you have reached 1 drop per week, then it could be 1 drop every 2 weeks, 1 drop every 3 weeks, and the lowering the dosing becomes lowering the tapering, longer the tapering period should become. So what we have understood from all this is that steroids improve clarity, antivirals ensure cure. We cannot judge the antiviral efficacy until the steroids are fully tapered. If there's an early recurrence, it means there was insufficient prior treatment and peripheral persistence of HSV, that means somewhere in the cornea. If recurrence occur on prophylaxis, check compliance, underdosing, or acyclovir resistance, or check triggers, prostaglandin analogs, YAG capsulotomy, or some surgery. In case the steroids are indicated, the cyclosporin can come to use. Oral acyclovir reduces the severity of stromal disease and the frequency of recurrence for as long as it is given. And in some cases, if the need arises, the prophylaxis can be given for as long as the patient is alive. So thank you.
Thank you so much, Dr. Tarun. I think it couldn't be a more comprehensive and a very well depicted HSV keratitis, which it's a very complex. You can stop sharing the screen. So, which is a very complex disease scenario and doesn't look as simple as it looks. So, Merle, you have a lot of experience on treating HSV patients. So, would you like to give couple of points of advice to the residents and other people what they should, be looking for mainly?
Yeah, so I think so while all the clinical features that Dr. Tarun described are pretty kind of straightforward, where the confusion arises is when you have HSV necrotizing stromal keratitis, because you have a lesion that looks like an ulcer, and ultimately if you're doing a microbiological workup, that's fine, you may not pick up anything and then you get confused. So I think those are the cases which are very important to kind of spot early on, because we've seen cases which are being treated with multiple medications like you alluded to earlier, and they don't actually respond and they start becoming worse and worse and they tend to perforate. So I think some of the clinical points that we have to look at for HSV necrotizing stromal keratitis will be clinically, one, if you have a patient who presents to you, they may usually be relatively less symptomatic as compared to a person who has got microbial keratitis. They don't have the features of discharge and, significant amount of lead edema that a patient with microbial keratitis has. When you're looking at the cornea per se, they would have this whitish kind of an infiltrate, but the area of the infiltrate doesn't always correspond to the epithelial defect. Normally in microbial keratitis, epidefect, infiltrate, they'll coincide, and you have an infiltrate that extends beyond the borders of that epithelial defect. But in HSV NSK, what we normally see is a very large or bizarre shaped epithelial defect and an infiltrate that is somewhere else, maybe within that area, but on one side or extending beyond it. And that infiltrate per se would be whitish, plus there may be deep vessels, there may be signs of footprint scars, there may be signs of an sectoral iris atrophy, indicating that there have been past episodes. So, and then if you stain, if you catch the disease early on, and if you're the first person to see it, and you stain, that epithelial defect sometimes takes up a geographic pattern, and that's another clinical clue that you're dealing with an HSV. But then when you're treating these patients, I think it's important to treat them on the lines of microbial keratitis first. That is, you scrape, you try and figure out whether there's something growing there. There might be a secondary infection, though not very common, and wait for a couple of days for the cultures. What we have had experience with is if you're strongly suspecting HSV and the patient has been on treatment elsewhere, received antibiotics, received antifungals, so we stop all of that. We just put them on cycloplegics, give them oral acyclovir 5 times a day, and then call them again after a couple of days while we're waiting for cultures. So what happens is that in the meanwhile, if it's viral, it does tend to show some signs of response. If there's a secondary infection that's lurking there, then that'll get picked up in the cultures. And so then if you see signs of response, nothing growing in cultures, that's when you can start steroids. And like Dr. Tarun mentioned, is that you try starting a lower dose. Yes, it's a very large defect, you would start with a lower dose, but you need to remember that there's a lot of inflammation happening in the cornea, and usually it doesn't start resolving very quickly. But even 4 to 5 times a day or 6 times a day of topical steroids does help these patients, and you can step it up if you find that the inflammation is too low. You can use oral steroids as well. That is helpful because it does prevent the problems that we have with epithelial healing in these cases. So you can even give oral steroids if you find that there's a lot of intraocular inflammation.
Yeah, I think it's very important to check for corneal sensations as well, in these cases, because a lot of times they're the key to your diagnosis. And plus, head study was done without topical acyclovir. So we do have an advantage of having topical acyclovir with us, because in US topical acyclovir is not available. Dr. Rama, just a quick question that when do you decide to give oral acyclovir versus oral valcyclovir? So is there any indication that you would use that or this?
My experience with valcivir is very limited. My oral acyclovir is my go-to drug of choice. But there are some patients who have frequent recurrences where you have to keep them on long-term dosage where the number of times they have to take the medication becomes a little more. So in those patients, I may prefer, if there have been frequent recurrences with acyclovir, then in terms of reducing the number of dosages, I may prefer valcivir. Otherwise, my go-to drug still is oral acyclovir. I'd like to hear from Dr. Merle about her thoughts on valcivir.
Yeah, so I too use acyclovir. I mean, valcyclovir, even though it's there, not being used by me that much. I think our retina colleagues have got better experience using valcyclovir because they use it for ARN and PORN, and so they do have better experience with that. But frankly, I just use acyclovir. I think patients, using it 5 times a day does become a problem, and that's what we start them on. But then once they go down to prophylactic dose of twice daily, I think they're quite happy to take that.
Quite happy.
So
Right.
one quick comment, if I can make, I think this is
Yes.
about the post PK. Actually, I think when you have done a cornea transplant post viral, reasonably sure it's viral because you've been treating the patient. When the confusion sometimes is when there is a viral recurrence versus when there is a rejection. I think that there is because the clinical symptoms can be almost the same. You can have patients who are photophobic. You can have patients who have signs wise they can have edema, KPs, little bit of AC reaction. I think it's important to look at where the KPs are located because in case of a viral reactivation, you're probably going to have it all over the cornea, whereas in case of a rejection, the KPs are predominantly going to be limited to the donor cornea. That gives you a cue about whether you're dealing with a reactivation or a recurrence. But sometimes I think we also have to consider the fact that both can coexist at some point of time.
Right. So definitely we need to understand that, a lot of vascularized scars in which we do an optical PK, there could be a recurrence of an HSV rather than a rejection. So we need to rule out which one is what. Thank you, Dr. Tarun, for a very comprehensive.
One point
Yeah.
for the neonatal conjunctivitis. I think it's very
Yes.
important for those kids to be referred to a pediatrician, because if it does spread and become meningitis or encephalitis, it has got a 50% mortality. So it's very important that they receive parenteral acyclovir and refer to a
Right.
pediatrician.
Absolutely. Yeah. Thank you. Thank you. So we move on to Dr. Sarita Agarwal, who's going to speak on eye banking, donor selection, and corneal storage. Over
Yeah,
to you, Dr. Sarita.
yeah. Thank you, Dr. Swati, for the introduction. So, good evening, everyone. I would be speaking on eye banking, donor selection, and corneal storage. So, I will start my topic with the famous saying, Sarvendriyam Nayanam Pradhanam. Of all the sense organs, eyes are the most important. So I will talk about what is an eye bank, importance of eye banking in India, then gap between demand versus supply, objectives of the talk, scientific plus practical understanding. So iBank is a specialized organization that recovers, processes, evaluates, stores, and distributes ocular tissue. It's a non-profit community organization governed by a board of directors or trustees constituted by community representatives. And it ensures safe, ethical, timely supply of the cornea for transplantation, research, and training. So, about the historical evolution of eye banking, the first successful human to human corneal transplant was done in 1906. In 1935, Filatov introduces cadaveric corneal donation, and first modern eye bank was founded by Patton in New York City in 1944. In 1961, IBA established first medical standards, and about the medical era, there is organ culture, optisol, GS media, laminar graft, and preloaded tissues are discovered. Eye banking evolution in India. The first eye bank in India was established at Rio, Chennai in 1945 by Dr. R.E.S. Muthia. A national eye bank was established in 1965 at AIMS, New Delhi, under the guidance of Professor L.P. Agarwal. NEB plays a pioneering and leadership role in development of eye bank services in India, and its roles are policy planning, formulation of national guidelines, and establishment of standardized protocols. So a word about NPCB, that is National Program for Control of Blindness. It's a centrally sponsored national program that was started in 1976. It aims at reducing prevalence and burden of avoidable blindness, and it helps in funding in eye banks, establishment and eye donation centers. Then there is the Eye Bank Association of India. It was established in 1989. It's a central body for unification and guiding of eye banks, setting and common protocols and spread public awareness about eye donation. So every eye bank should have the member of Eye Bank Association of India. Hospital corneal retrieval program, it facilitates eye donation by trained counselors from families of deceased individuals in hospital and motivate them for eye donation. It provides access to potential donors, their medical history, and the shorter time between death and retrieval. Hence, better quality of ocular tissue is retrieved. So why eye bank matters today? Corneal blindness is a leading reversible cause of bleeding vision loss. 85,926 corneal transplants performed in 2024 globally, and about 10% of all the cases are treated with bikeratoplasties globally. And in India alone, 2.7 lakh donor eyes are needed to achieve 1 lakh transplant per year. So what are the core principles of eye banking? Quality assurance, availability of the corneal tissue, safety and standardization. So in our country, 4.8 million are corneal blind persons in India and 37.5% prevalence in overall population of blindness. And to this data, 40,000 to 50,000 people are added every year. And 32,414 donations are done so far. What are the objectives of the eye banking? It maintains aseptic recovery, environment, and proper donor maintenance. It ensures complete donor screening and eligibility determination, performs tissue evaluation, microscopic examination, then slit lamp grading, specular microscopy, and organ culture and distribution following the quality benchmarks. This is about the steps to safety eye tissue distribution. So first, timely retrieval is done. And after that, aseptic recovery that maintains a sterile environment during tissue recovery. Then donor screening is done. And after that, tissue evaluation. And there is a detailed examination of tissue quality using various methods. And safe storage is done of the corneal tissues. And after that, ensuring tissue is distributed according to the established standard guidelines. So what should be the structure of the workflow of the eye bank? Our eye bank has a three-tier system. Eye banking training centers, the apex one, and it is for the training and research center, and under which eye banks comes, and the function is primarily processing, evaluation, and preserving center. And then there is a eye retrieval and donation centers, and that is for community and hospital-based retrieval units. So what are the function of each tier? Eye retrieval center, it awares generation, then counseling families, harvest corneas, collect serological samples, and safely transport tissues to the eye bank. Eye bank has 24/7 donor response system, HCRP coordination, retrieve the cornea, process, preserve, evaluation tissue, and distribute tissue for the keratoplasty. And eye bank training center, under which all the eye bank functions, and it trains technicians and counselors and doctors, and used for research purposes also. Then an eye bank can designate and delegate multiple responsibilities to a person as appropriate if necessary. So what should be the facilities and equipment requirement in an eye bank? It's slit lamp, lamellar flow hood, refrigerator, sterile recovery kits, storage medias, and adequate space for tissue processing, evaluation, storage, and administrative function. Now the optional is specular microscope, incubator, OCT, centrifuge, and sterilizer. So what should be the specification of refrigerator? Internal or external for continuously recording the temperature. Inside must be cleaned periodically with a hospital grade cleaning system, and it must be solely used for storage of tissues. And it must have clearly segregated labeled areas for storage. And it must have a contingent plan for multifunction or power failure. The lamellar flow hood, that the particle count should not exceed a total of 100 particles per cubic foot of size 0.5 micron and larger. It must be cleaned and disinfected before use between tissues from different donors. And after that, recovery instruments for corneal excision or enucleation set is needed. Instruments must be inspected frequently enough to assure that they function properly and shall be suitably decontaminated and cleaned prior to sterilization and reuse. And all the sterilized instrument supplies, reagents such as corneal preservation medias must contain sterilization dates and expiry dates that are current all the times. So these are the infrastructure, what should be present in all the centers like slit lamp and specular microscope. The EBTC and eye banks are required, but in eye donation retrieval centers, it is not required. Then refrigerator is required in all the three centers. Then lamellar flow hood, it is required in training centers and eye banks, but not in retrieval centers. And again, the autoclaving, that is required for EBTC, EB, but not required in retrieval centers. And instrument set, that is required in all the centers. So this is the complete workflow of eye banking, how eye bank function actually. So what happens after once the notification of death received, the initial screening is done for assessment of the donor suitability. And after obtaining consent for donation, there is maintenance of the donor's body and serological sample is collected. And after that, corneal tissue is retrieved even by enucleation or corneal excision. And after that, it is processed in class 100 hood, and the tissue is evaluated using slit lamp and specular microscopy, and it is preserved in preserving media. And after this, it is ready for distribution after ensuring traceability and quality assurance. So donor screening and eligibility check. Before touching the donor, the eye bank must evaluate the cause of death, illness, ICU course if any, infection risk, behavior or social history, contraindications, serological requirements, and documentation checklist. Any high-risk behavior, unknown fever, sepsis, hepatitis infections, that excludes a donor. So the purpose of donor selection is that ensure safety so that there is no disease transmission, quality of corneal tissue, compliance with legal standards, then ethical and traceable donor practices. And India's eye banking standards highlights the need for proper eligibility determination, safe tissue retrieval, and compliance with NOTO guidelines for transplantation. So what are the NOTO guidelines? That is National Organ and Tissue Transplant Organization. That is the apex body in India coordinating organ and tissue procurement and distribution. And the guidelines are governed by THOTA, that is Transplantation of Human Organ and Tissue Act 1994 and its amendments. It's a legal framework to support eye banking system, and it even allows RMPs to harvest the eyes. And in 2011 amendments, it allowed trained technicians to retrieve donated corneas. And about the recent update in 2024, One Nation, One policy that aimed at standardization and streamlining the process of eye donation and transplantation across the country. So as per the latest update, now the specular microscope use in eye bank is optional. So what is State Organ and Tissue Transplant Organization? That's a state level body responsible for actual implementation of rules, managing the state's waiting list and coordinating organ allocation within the specific state. And the core responsibility of SOTO are organ allocation, waiting list management, green corridors for faster transport, and about one donation, one policy changes in 2024-25. Domicile certificate is no longer required now. And the age limit is also removed. And the patient and donor guidelines state-wise. So what exactly is there? If you have an eye bank, you have to report the SOTO daily, whether you have done retrieval or not, or whether you have done keratoplasties or not, you have to mail SOTO every day. So what are the sources of donors? You can retrieve the cornea from hospital corneal retrieval programs, then eye donations from deaths in community or at home. Then eye donations can be achieved from brain dead donors with THOTA approval, and medico-legal cases after clearance with police. So that's a donor eligibility workflow. Initial donor call, you have to fill the form, then just see about the medical history, review the hospital records, physical inspection is done, then apply systemic and ocular contraindications, determine the suitability and proceed for recovery. Consent and family approach, you have to take, legal consent is mandatory, written documentation is also very important, and grief counseling approach is always helpful, and use of authorized forms. And family approach must be done with sensitization, and grief counselors are trained in communication, ethics, and documentation. There are some forms and certificates which are to be filled after the corneal retrieval. You have to give the letter of appreciation to the patient's family. About the eligibility criteria, there is no strict upper limit. So even more than 80 years acceptable for therapeutic uses, including newborns. And time since death, in situ excision, ideally it should be done less than 6 hours. And if you are planning for enucleation, that should be done up to 12 hours. And there is no active ocular infection and clear cornea on gross inspection. The systemic contraindications are hepatitis B positive, rabies, septicemias, Ebola virus infection, disseminated malignancy, unknown cause of death, EBA, then active untreated tuberculosis or severe systemic viral infections. And there are some relative systemic contraindications like leukemia, lymphoma, active malignancy other than the CNS, and prolonged ICU stay with high dose vasopressors, and unexplained fever before death. The medical director may approve tissue for therapeutic and lamellar graft if systemic conditions do not compromise corneal clarity. Absolute ocular contraindications are panophthalmitis, corneal infiltrate, corneal dystrophies, advanced pterygium, and recent intraocular surgery that is done within 3 months. And relative ocular contraindications include arcus senilis, pseudophakia, previous LASIK, and mild stromal scar. So there are some medical serological testing that is mandatory doing, like all the HIV testing, then COVID-19 and syphilis. An optional test, malaria and dengue, and serology is usually performed on post-mortem blood samples. So donors which are usually considered acceptable are elderly donors, cataract operated eyes, pseudophakic donors, diabetic donors, then mild glaucoma history and treated systemic infections, those are non-septic, and even newborn donors are considered acceptable. And as per the Indian standards, there is no age limit ensuring maximum utilization where demand is more than availability. And final suitability decision is made by medical director or trained delegate staff. So some documentation is required after retrieving the cornea. So the donor call form or medical particulars, the consent form from the relatives, then serological reports, all the recovery notes, processing log, evaluation reports, and distribution records. So what should be the interval between death, retrieval, and preservation? Time of death varies according to the circumstances of the death, storage of body after death, and storage of tissue between enucleation and preservation in medias. Within 8 hours of death, if the ambient temperature is not hot, and if there is an unknown time of death, estimate hours passed depending on the information available and keeping in view the higher risk of infection with longer intervals. And hot ambient temperatures within 6 hours of death if the ambient temperature is hot, and up to 12 hours of death if the tissue is continuously cooled within the above constraints. And the above time requirements may be waived off if tissue is continuously refrigerated and deemed medically suitable by medical director. So the corneal retrieval technique, it can be enucleation technique or corneal button excision. Now there is a donor maintenance form. So after confirming death certificates, written consent, documentation, and family sensitization, instill antibiotic drops to prevent the infection, then moisten the eyes with VSS or saline solution, and tape the lids and apply wet ice packs to reduce swelling and pain, and elevate the head to maximize pressure and swelling. So what is the purpose of tissue recovery? Corneal retrieval aims to recover tissue aseptically, preserve endothelial integrity, it maintains sterility, avoid trauma and contamination, and enable high quality tissue for keratoplasty. And retrieval is one of the most critical determinants of whether the tissue becomes optical grade, therapeutic, or unusable. So collection of post-mortem blood, usually we take 10 ml from femoral vein, so that all the serological reports can be done after the retrieval. Then about the corneal evaluation. So what is the purpose of tissue evaluation? To ensure the tissue safety, tissue quality, and suitability for optical, lamellar, therapeutic, or research use. And when evaluation is performed after the cornea is placed in storage media, within 2 to 6 hours of retrieval, repeated before release of transplant, and performed by trained eye bank technicians under medical director. And early evaluation helps to detect epithelial sloughing, stromal edema, and endothelial compromise. So what should be the components of tissue evaluation? It includes macroscopic gross inspection, then slit lamp biomicroscopy, specular microscopy, pachymetry or thickness estimation, and quality grading and documentation. So again, you have to see for the corneal viability, to see any epithelial defect, epithelial edema, scars, foreign bodies, keratic precipitates, arcus senilis, corneal catata, and endothelial cell count. So critical cell density, if if there are 300 to 500 cells per millimeter square, and functional cell density if there are 1500 to 2200 cells per millimeter square. So this is the grade system by All India Institute. So if tissue is considered as excellent, if there is no epithelial defect, the stroma is crystal clear, there is no arcus senilis, no folds in Descemet's membrane, and there is no defect in endothelium. So that tissue can be considered for optical grade. So this is the tissue grading. For optical grade, we actually see the clear epithelium, clear stroma, no infiltrates, minimum folds, and endothelial cell count that should be more than 2000. And if there are stromal scars or infiltrates used for perforation, that could be used for perforation or ulcers. So what is the final acceptance criteria of retrieved cornea? If there is no contamination, that ensures the tissue is free from harmful substances, wherein all the necessary assessments are done. If the serology comes to be negative, ensures the tissue meets specific standards, and if final authorization by a medical professional and adhering to the regulatory guidelines for transplantation. So that is the final accepted criteria. Now, the next very important topic is corneal storage. So the purpose of corneal storage is to maintain endothelial viability, prevent contamination, ensure optical tissue quality, allow safe transplantation, transportation, provide predictable suitability, and storage is a critical control point. If there is an improper storage, endothelial cell will be lost and the chances of graft failure will be more. So if the short term, we usually store the cornea for 2 to 3 days in MK media. For intermediate storage, that is for 7 to 10 days, usually we use cornisol, and for long term, say 30 days, organ culture media is used, and very long year cryopreservation or glycerine preservation tissue is used. So preservation of cornea is done in moist chamber storage. Storage for whole globe done at 4 degree centigrade, and it can be used for 24 hours. This is a simple preservation medias, but there are chances of stromal edema. Moist chamber. So the preservation of cornea in tissue media, the contents are dextran, chondroitin sulfate, electrolytes, antibiotics, essential amino acid, insulin, epidermal growth factor. So this is a MK media. We usually store the corneal retrieval tissue for 3 days. And K-sol, it's a purified chondroitin sulfate in tissue culture media, and storage is done usually for 7 to 10 days. And long-term organ culture storage system that is developed by Harry Eagle and done at 34 degrees centigrade and incubated at room temperature in nutrient medium, and the storage time is usually 30 days. This is again, if you want to store the cornea for short term, better to use the MK media. For intermediate, we usually use cornisol, and long term organ culture and very long term cryopreservation or glycerine is used. So what are the future directions in eye banking? As you all know, there is a growing burden of corneal blindness and there is limited donor supply. And the demand is increasing for endothelial keratoplasties nowadays. And there is a global push towards regeneration and cell-based therapies. And there are new technologies that aims to increase unusable tissues, reduce wastage, and improve graft survival. And the advancements in eye bank nowadays is preloaded lamellar grafts, endothelial cell therapy, improved storage technologies, digital eye banking management system, and expanding hospital cornea retrieval programs. So the future directions are eye banks preparing pre-cut, pre-stripped, and preloaded grafts, preloaded DMK, DMX scrolls, and pre-cut DSEC lenticules that reduces intraoperative manipulations. These are most common cause of primary graft failure. So the expanding roles of the eye bank nowadays is expansion in the role of eye bank personnel, ophthalmologists, trained technicians, and counselors, upgradation of eye bank facilities for pre-cut donor tissues, standard operating procedures and data managements, technological upgradation and integration, and beyond the supply of corneal tissue, the sclera, amniotic membrane, cell-based corneal endothelial therapy is also used in eye banks. So these are some SOPs and certification which you have to use in your eye bank. Then eye donation fortnight, that is a very useful initiative by IBAI that is celebrated every year from 25th August to 8th September. And this is how we are using our unused tissue, means the tissue which are not very good grade. We use them to teach our PGs for corneal suturing, for manual grafting, or for manual lenticule preparation. So I will conclude my talk. There is no lovelier way to thank God for your sight than by giving a helping hand to those in the dark, by Helen Keller. Thank you.
Thank you so much, Dr. Sarita. That was very comprehensive, elaborate, and I think eye banking is such a scenario that every corneal surgeon needs to know and should be knowing. And I would ask Dr. Rama if she has any thoughts on the eye banking scenario in India and how it should be.
So I think, like she elicited beautifully, there's a lot of gap between supply and demand. And there is also a considerable amount of tissue that is not being utilized to its optimum capacity. So the way forward, I think, is like the initiatives that have been taken by the government and several institutions, is to see how best we can do the tissue sharing of excess tissues. Already NV Prasad is doing that, I think. So a lot of institutes are doing that, where we take tissues from them and we minimize the wastage. The one other thing that has come up is the hospital-based cornea retrieval program, which can actually be given a boost to be done in a big way, because lot of the debt that happens there is of people who have relatively good donor quality tissue. So I think a little bit focus on placing counselors along with the hospital cornea retrieval program can actually go a long way in increasing the tissue recovery and decreasing the demand. But I think we still have a long way. I think it has to come from within. It should be a movement, basically. It is like everybody has to feel the cause, feel for the cause, and only then it's possible for all these things to take shape in a big way. One thing I think is also, I just wanted to add to this. I saw that COVID screening is a part of the screening protocol that they are doing. I just want to ask you and Dr. Merle, while we take the history from the Pay family, but are you still doing any screening for COVID in these donor corneal tissues?
No. So we were doing it initially when COVID had started,
During
but
COVID,
now we
yes.
have stopped. Yeah, now we have stopped. We don't do it anymore because most of we already have a vaccination done. Most of this, unless it's a death proved by COVID anyways, it's kind of a viral fever which is unexplained, becomes a contraindication to corneal donation. But then we don't do it as a routine. Merle may be able to answer.
We don't do it either. Yeah.
Yeah. Yeah. So another thing I wanted to ask, if Dr. Sarita said, we can take corneas of infants also, so I just wanted to check, are we taking corneas less than 1 year old?
No.
No. Okay.
It's very difficult to suture with those. Maybe Dr. Sarkar will highlight that in his talk, the age of the donor. They're very elastic tissues, they're very steep corneas, and it's very difficult to suture them. So I think we avoid taking infants. We can use LASIK. I mean, people who have undergone refractive surgery can be used for endothelial keratoplasty, particularly since we're harvesting scrolls. I think we can use that. But I just want to make a point, so we have been talking about how that we don't have enough tissues and stuff like that, but we've reached a scenario where there are certain eye banks which are like, and I'm sure that you face this issue as well, Swati, is that in Rajasthan you probably have surplus tissues
Yes.
for your area, and it's a similar scenario with us in Andhra and Telangana as well as in Odisha, but we don't have a unified corneal registry for the whole
Yes.
country, and that would be something that would be that would really help, because if we could match, and that was something that was started by SightLab but then kind of went into oblivion.
Right.
We could have a common platform where everybody registers their patients, and it just gets populated on a who's requiring it most, and that kind of criteria if we set up. And if we have a tie-up with all the, if the aviation industry chips in to help, because
Right.
currently they kick up such a huge fuss to transport corneas, and it's such a, I mean, it's a real pain. I think if we have some
Right.
aviation industry, we should actually try and tie up with them so we can transport corneas all over the country. I think that would go a long way. And then the required request law, if the
Yes.
in Delhi, if they make it mandatory for anybody who passes away to give their corneas, and like how you have it in the US, I think we'll be doing a much better job in terms of transplants.
That'll be like a dream come true,
Yeah.
obviously. And we were the first state in Rajasthan, so that was one that in at the back of the driving license, we kind of write we are an organ donor and an eye donor, and there's a heart that comes. So this has been started by the government of Rajasthan, but definitely without the consent we cannot take. So a required request would be an ideal situation to go about. So thank you,
Ma'am,
Dr. Yeah,
I would just like to add one
yeah,
point. I know
Rolika.
that even though I'm from oculoplasty and oncology, but I would just like to add one point that in Rajasthan, what ma'am said that there are surplus cornea. You'll be surprised that I met some teams who are non-ophthalm teams, of course, but they are running hospitals, and they actually said that what's the point of even these corneas? They just go waste, and they did not even know that the concept of transplant, exists and how we are actually providing visual rehabilitation. So I think a major drive for even educating even the hospitals would be so important and useful.
Right, Rulika. We understand because Rajasthan, as I consider, has been a backwater for any kind of a donation. But then definitely an awareness is what is needed everywhere, and probably that's why the shortage is there because there's lack of awareness. So thank you,
Right,
Dr.
ma'am.
Sarita, for an excellent presentation and an overview. Now we move on to
Yeah.
Dr. John Sarkar for the next presentation and A to Z of how to do a corneal transplant for residents.
Good evening, ma'am. Am I audible, ma'am?
Yes.
Good evening to all my teachers. Dr. Ramaya, ma'am is there. It's very privileged for me, but ma'am was my finished mentor also. Thanks to AIS meanwhile sharing my slides. Uh, my slide is visible. My slide is visible.
Yes, sir.
Yeah,
You can go on PowerPoint mode, sir.
yeah. So learning is the evolutionary process, and we are here from couching to chopping. And so I'm sharing these slides for this presentation, especially for the resident. So these are the patient who came to our cornea OPD with profound visual impairments with this corneal clinical scenarios, starting from the infection, scar, decompensation, or some of the congenital or inherent degeneration. So what the smart answer for all these cases? These are special case scenario, and the corneal transplantation and keratoplasty is the smart answer for all this clinical scenario. So for next couple of minutes, I'll be discussing the A to Z of keratoplasty. That is resident must know. I have no financial interest. So I'll be following points. I'll be highlights of what is the keratoplasty, types of keratoplasty, indications, basic surgical technique of the different types and complications and the rejections and the recent advance in the keratoplasty. And most of my presentation, video-based presentation. So why we should know the keratoplasty first of all? That is already published in Indian Journal of Ophthalmology by Nupur Gupta Madam et al. It has been found that in India it is estimated approximately 6.8 million people who have vision loss and less than 6 by 60 in the almost, and it has been found that among these people 1 million people are bilateral blind, and the number has been reached more than 10 million over the year 2020. So there is a huge scope for the learning for the keratoplasty and do something to enlighten these patients. So that's why we should, at least being an ophthalmologist, being a resident, we should know the basics of the cornea transplantation. You may not do with the cornea surgeon in future, but you should have a basic conception that at least whenever a patient come to us, that you can manage this patient or you can refer appropriate referral. So what is keratoplasty? From the first documented successful corneal transplant performed by Edward Conrad Serum in 1906 to contemporary femtosecond laser assisted surgery, the evolution of keratoplasty has been nothing short of remarkable. Corneal transplantation or keratoplasty is a surgical procedure in which the abnormal corneal host tissue is replaced by the healthy donor cornea. The types, what are the types? For the penetrating keratoplasty, when the full thickness of the cornea are grafted. And the lamellar keratoplasty, when the partial thickness are grafting, it may be anterior or it may be posterior. So there is a schematic presentation. The red part of the eye showing this thing when the entire whole cornea is transplanted, that is a penetrating keratoplasty. When the part of the anterior stroma is transplanted, the anterolamellar keratoplasty, when the almost till the deep descemet membrane, it transplant entire whole transplantation on whole stroma, except that still that descemet membrane is transplanted. It is the deep anterolamellar keratoplasty. When the posterior stroma will be part of the endothelium, descemet membrane, and the part of the posterior stroma is transplanted. It is called the DESSEC, descemet endothelial keratoplasty, or only the when the descemet membrane transplanted, that is called the DEMEC, is the most recent advance in the lamellar keratoplasty. Now we move on to the general indications. When the corneal transplantation is performed for the vision purpose, that is called the optical transplantation. Keratoplasty is performed to improve the vision. Important indications include the decompensation, mainly the PBK or aphakic bullous keratopathy, keratoconus dystrophies, degeneration, and scarring may be caused by the trauma or post-infection. Tectoning, when the grafting may be carried out to restore the or preserve the corneal integrity in eye with a severe structural changes such as the severe thinning with impending perforation or descemet to give the support to the contour of the eye, that is the tectonic grafting can be done, or therapeutic. When the corneal transplantation may be offered, removal of the infected corneal tissue in eyes with unresponsive or not amenable by the antimicrobial therapy to save the eyes, to salvage the globe. When the infection, to control the infection, when the transplantation done, that is called therapeutic transplantation, or cosmetic, when the grafting may be performed to improve the appearance of the eye, or but is very rare indication. Now the substitute also the by tattooing can be done, but this is one of the indication too also. So what are the prognostic factor? So before go ahead to the transplantation, we should know to whom we are doing the transplantation, what the survival rate of the graft. Those there are some of the prognostic factors are there. Those are severe stromal vascularization, absence of the corneal sensation, extreme thinning at the proposed host cup junction, and the active corneal inflammation. Those are poor prognostic factor. So that has to be addressed before the transplantation. Abnormalities of the eyelids such as the blepharitis, ectropion, entropion, trichiasis, or this should be addressed before the surgery. Otherwise, the epithelialization of graft or the patient's surface, unstable surface and recurrent infection could be the could compromise the quality of the graft. Recurrent or progressive form of the conjunctival inflammation such as atopic conjunctivitis or ocular cicatricial pemphigoid, that has to be addressed by immunosuppressive systematically before going to the transplantation. Tear film dysfunction, that has to be addressed. Antiosynechia, uncontrolled glaucoma, and uveitis, that has to be the poor prognostic factor that has to be controlled prior to the transplantation when you are planning those who are comorbid condition. Now move on to the now already my previous speakers, I'm not going in details of the transplantation, but at least we should know which tissue we should use, which tissue we should not. That has been my previous speaker had been elaborated very nicely. I'm not going in these slides because already this has been discussed by previous talk. Now the penetrating keratoplasty. We move on to the first part of the penetrating keratoplasty. When the penetrating keratoplasty is a transplantation procedure in which the full thickness host corneal tissue is replaced with a donor corneal tissue. The objective of the penetrating keratoplasty establish a clear central cornea or visual axis, minimize the infective refractive error postoperatively, provide the tectonic support, alleviate the pain, and eliminate the infection. Anesthesia was before the corneal transplant. Most of the transplantation were done in the peripheral anesthesia, but the general anesthesia can be done especially the pediatric age group, extremes of age, when we are expecting there could be some of the perforation and maybe high positive pressure. In those scenario, probably the general anesthesia much more predictable rather than perivalvular block. And the surgical technique, before going to the surgery on table, this two to three thing checklist you should be know before prior to the any penetrating keratoplasty. One is the intravenous mannitol with probably 200 milligram IV mannitol preoperatively are giving to reduce the vitals of thrush, and the preparation of the donor graft tissue always first specifically if you are doing the open sky or the penetrating keratoplasty, donor tissue should be prepared prior to the cut your host bed, and host bed prepared, followed by the host bed should be prepared. And the determination of the graft size. What is the size of the graft? Types of the trephine and suture should be kept in mind. Usually the normal optical purpose, the graft should be at least whatever the pathology is there, at least scar or something, it should be at least 7.5 to 8 mm. If the graft is smaller than 7.5 or 7 mm, then there is a high chance of astigmatism should be there. If the graft is more than 8 or 9 mm, there is a chance of past formation or secondary glaucoma. The optimum size for the optical purpose is 7.5 to or 8 mm, and the therapeutic one, it may be the depending on the what are the extent of the infection involved in the cornea, it should be at least 2 millimeter away from the infected margin. So at least even sometimes it has been found that from the limbus to limbus big graft may be needed due to the therapeutic one. The type of trephination, usual disposable trephine we are using, and the size of the trephine, normal codes in optical purpose, and usually the graft size is 0.5 to 1 mm larger than the host bed trephination. In case of the flat, in the case of therapeutic or the slough out one, when the cornea SC is totally flat, usually we are using 1 mm larger trephination from the proposed host bed. The graft size usually 1 mm larger, 1 mm larger than the host bed. So usually that will help to from the anterior chamber reformation. Sutures, normally we are using 10 nylon monofilament and interrupter sutures, or it may be the it can be interrupted along with the combined continuous suture can be used. Now we move on to small surgical video for the resident. Here we do the partial trephination, followed by we form the high viscous substance from the IGB, mean Hilon GB we are using, and cutting the cornea. And the suturing done from the host side, graft side to host side, and it almost 90% thickness. Once it should not be full thickness. Once there is suturing is there, usually we can just run the video again. Once the suturing has been done, so usually we first put the cardinal sutures, one at 12 o'clock, 6 o'clock, 3 and 9 o'clock, followed by the rest of the 16 sutures are given. And usually prophylactically make an inferior PI to prevent the secondary glaucoma. And this, while suturing, it should be from the graft side to host side, almost 90%, just peridium label. So there is a opposing of the Descemet's membrane to Descemet's membrane, and the surgery is completed. So what is the post-op picture? Thing is that once we do this, the perfect corneal transplantation optical purpose, we can see there's a tomography of this patient of that care reading, and you can see the inferiorly the patient what the refractive power. Though the quantity of the vision is 6/9 in this specifically this patient, but you can see there's a high cylinder power is there, and there's a high astigmatism is there. So probably so excuse me. So probably this is the reason. Though there is a quantity of the vision is achieved 6/9, but the quality of the can see there is a high astigmatism is there. So that's why we have to move. Why we are moving to the now the lamellar one. So why there is a lamellar keratoplasty over the penetrant keratoplasty? It in lamellar keratoplasty it avoids an open scanning procedure, minimal induced astigmatism, and a smooth anterior corneal surface, and the and your suture related graft and rejection is less, better tectonic stability. As here we are mentioning this thing, the entire whole cornea is here is maintain these things because of the technical stability much. We are not making the 360-degree aperture of the 7.58 millimeter. So there is a technical stability much better compared to this thing, and less chance of expulsive hemorrhage, avoidance of an anesthetic donor cornea in the early postoperative period, reduce graft failure from the ocular surface disease, allow an earlier return of the refractive stability and good visual acuity, and there is a less chance of expulsive hemorrhage or supracortical hemorrhage during the surgery. So why you can see these things, there is a when we do a lamellar keratoplasty as compared to the penetrant keratoplasty with the right side, my this slides there is a 40. You can see the superior reading. The care reading is 47, and the steeper one, the thinner one is 40, almost 5 diopter difference is there, where in case of lamellar one, there is only 3 diopter difference is there. Even both are in the showing the keratometry reading at the end of 6 weeks. The same thing when you see this, they compare the post-operative differential correction of the two different patients having the one underwent the penetrating keratoplasty on the lamellar one. We can see the cylinder here. The first one on the right side, there is only 7 cylinder is there, whereas in case of the list one, there is only 2 cylinder is there. Even excuse me, even we practically we compare the even also practical scenario when you compare the real-time post-operative picture to also we can see at the we retain the suture at least minimum 4 to 6 months, whereas in case of lamellar one we can cut the suture at these things. And even also when I compare this lamellar one with the endothelial keratoplasty, we can see the how much technical stability is there. So that's why now the transplantation we are moving to the from the full thickness to lamellar one, lamellar transplantation. When it is for the endothelial purpose, so the endothelial keratoplasty dysecondemic. When it is for the endoscarring, stromal scarring, with most of the cases, we are moving to the either DALK surgery. So surgical technique of the deep enterolamellar keratoplasty when the endothelium is healthy, but the pathology remain in the within the 90% of the corneal stroma. So this surgical video showing these things, the one of the. So we are doing the partial definition is there. This is the case of the keratoconus with the apical scar is there, and that's why we're doing the layer by layer dissection is there. 90% of the stroma are, and 60% of the stroma are removed by we insert the blood dissectant and air is injected. So here actually we purposefully not doing the big bubble here. Once the almost 90% stroma is reached, we just peel off the endothelium from the donor tissue. That endothelium can be used for the demic purpose, and the remaining stroma without endothelium on suture on the top of the descendant segment. Here also suturing done by 90% thickness of the corneal stroma, and the surgery is completed. I am moving to the big bubble technique here. That is also the descendant DALK surgery. Here, part of the almost 60% cornea is debulking by the definition by lamellar dissection. Then a 26 needle is inserted in the stroma, remaining part of the stroma. We are encroaching the stroma and air is injected to separate the posterior stroma and make a big bubble to separate the posterior stroma from the descemet's liver. And you can see there's a big bubble formation. We look at this central part, and as usually I prefer to put a spatula and we remove the remaining part of the stroma and just a flower petal pattern. We remove the rest of the stroma, and the remaining part of which is remains same. So here is actually one of the patient who having the granular dystrophy with the nucleus clivaris 2. We have done the DALK with the phaco, and you can see this is the preoperative picture and this is the postoperative picture. So these are the innermost part. A few of the granules are there. That is a stromal part. It is approximately 66 micron of the patient, and the remaining part of the 90% of the stroma is was transplanted, and the patient maintained the 6/12 vision postoperatively. These are one of the patients who have both the keratoconus with erosion marginal degeneration (PMD) And we can do this patient with them. And we have done the DALC for this patient. And this is the post-operative picture of this patient. Patient maintained 6/9 vision maintained for almost last 3 to 4 years. So that is the advantage of the DALC over the penetrating keratoplasty, is that the tectonic stability is more, rejection rate is less, and the patient maintain the clarity of the graft, and early you can remove the suture, and the cylinder or the post-operative astigmatism is less. So these are the advantage of the deep anterolamellar keratoplasty. Now we move on to the endothelial keratoplasty. Endothelial keratoplasty, also referred to as a posterolamellar keratoplasty, it is a form of the corneal transplantation, where a donor's posterior corneal button, including the corneal endothelium, Descemet's membrane, and the posterior stroma, corneal stroma, or only the Descemet membrane, is used for replacement of the diseased corneal endothelium in the condition characterized by the corneal endothelial dysfunction. So here in endothelial keratoplasty, mainly the Descemet's membrane along with your endothelial cells and the part of the posterior stroma is transplanted, or only the Descemet's membrane along with the endothelial cells are transplanted. So that is the remaining where the stroma is healthy. So surgical methods are the Descemet stepping endothelial keratoplasty, where the dissection done manually, or DSAEK, where the graft is prepared by microkeratome. So automated endothelial keratoplasty, or DEME, where only the Descemet's membrane transplant, and it is the most recent advance in endothelial keratoplasty. What are the indications? There is endothelial dystrophies, bullous keratopathy. It may be the ABK, or it may be the PVK, pseudophakic bullous keratopathy, aphakic bullous keratopathy, endothelial cell failure, or iridocorneal endothelial syndrome, I syndrome, or endothelial decompensation, made by the TAS, or it may be the HSV endothelitis, or failed penetrating keratoplasty, or even of the post your optical PK or therapeutic PK. Now, the most of the cases nowadays, if the stroma is clear, we are not repeating the optical PK. We are doing the either DESEC or ultra-thin DESEC or the DEMEC. So, what are the pre-operative checklist for the endothelial keratoplasty? ASOCT must, which will give you the impression post-operatively how it will take the time to clear the stroma, because if the because what are the stromal scar or thickness, or what is the stromal hedge is there, that has to be assessed before going to the before going to the endothelial keratoplasty. Intraocular pressure, that has to be controlled or checked, and status of the lens, whether the lens is aphakic or it is a what is the pseudo or the cataractous lens. Because of that we have to address the things appropriately, and the sound posterior segment should give the proper post-operative visual improvement. So what is the importance of ASOCT? Here we can see the first picture. Though it looks like the hazy cornea, we have done the ASOCT for this patient. You can see that the bullous, but the remaining part of the stroma is real, not that much haze. So probably there is epithelial edema is there. So the left part of these things that has to be, that can be taken for the endothelial keratoplasty, but the right one is the stromal haze. But if I do the ASOCT, enter whole cornea haze. So probably that is not a good case or appropriate case for the endothelial keratoplasty. If you can do the endothelial keratoplasty, that will take a long time to take the newly transplanted cell to clear that stromal haze. So that is important for doing the ASOCT prior to the your these things with endothelial keratoplasty. So ASOCT is one of the must for the checklist. So what are the surgical techniques for the endothelial keratoplasty? The surgical technique, the basic concept of the surgical technique for the either the DESEC, we are considering the first of the manual dissection part, or ultra-thin DESEC, or in the DEME, where the donor tissue preparation, the surgery divided in three parts. One is the donor tissue preparation, and then the host bed or recipient preparation, methods of donor tissue insertion, and then followed by donor tissue apposition technique. So this fourth thing has been keep in mind, where in case of the automated DESEC, or in case of pre-cut tissue, or nowadays even also DEME, the pre-cut, the scrolled DM also available. In those cases, the donor tissue preparation is you can bypass the things, but as a resident, we should know the things how to prepare the donor tissue in case of ultra-thin DESEC, or in case of the DEME, and then followed by the recipient preparation method. That is same for all the endothelial keratoplasty method. That's the scoring of the DM, and methods of donor tissue insertion and the donor tissue apposition technique, that is differ. in case of the dissect and demate. So we are discussing here the how to prepare the donor tissue preparation here. So we just this artificial antechamber, just mount it on the Catarina 1. We don't have any financial interest. We can check the thickness of the by intraoperative pachymetry and in diamond usually what are the corneal is available either 300 or 400. Normally we are using the 400 if the corneal thickness and we check this. So we start with these things by the crescents followed by this customized instrument, the lamellar dissector, and it's very smooth. Once you get a plane, it is just like that. It is unedited video. We cut it, we punch it and give the elon JB and we just fold it. And the stomal side we mark by S marker. And the tissue is prepared. Now move on to the things recipient preparation. Once the tissue is prepared, we keep it in the galley pot and cover it should not be dried. Then we scored the DM by reverse inscript. This is very smooth, just like a Rexis. You can just remove it from one side and you can change the hand and the scoring of the dustbin and the DM has been just rolled out, just like you one of the folded your chapati and roti, it can come out very smoothly. I'm just repeating these things. We score the DM. And we just by reverse we rolled up the things. The method of donor tissue insertion. So usually we can very basic. This is a very old surgery purpose placing here. Most of the time here actually we fold it in the taco fashion with 40-60 taco and insert these things. So here by Uttrata forceps we are inserting these things. And once it is in the anterior chamber, we unfold it by the BSS solution. Unfold it and we just and once it is in central, we place a small amount of the air bubble and make it central. And the wound is sutured. Here we are another one insertion technique I'm showing here. This is very shallow. This is ultra thin graft. So once it has been done, we give us very small amount of the air bubble. As my graft is smaller, so it rotated like a spinning graft. So it should be adequate one. I'm struggling for that. Then I suture the main wound and drag the graft. I'm centrally and then I'm still struggling. So it should be appropriate size also. Usually the dissect graft should be 2 millimeter smaller than the horizontal diameter. But sometimes when the AC is very shallow, we should be very smaller graft. And this is another, we can use the graft glide also or needle insertion technique. This is another technique. We can insert the graft simply the needle endothelial side down and give the close the wound, or you can put a single suture first and gently unfold mesallian and the graft is and the whole chamber should be here should be given. And the glides, it may be the disposable glides can be available, and we can use the Bussen glides or 10 endo glides by Donald Tan. So this is one of the Bussen glide is there. So endothelial cells are endocyte is down and insert through the main 12 o'clock position, and diagonally is the 12 or 6 o'clock position. We make a small the one of the another wound, and from there by the microbial force we can pull these things into the graft, and we can without struggling we can insert this thing Bussen glides. So glide is one of the good option for the insertion of the graft in the anterior chamber. Now we move on to the DEMEC. What is the next? So DEMEC is the most advanced technique where the endothelial, only the endothelial is transplanted. I'm just sharing the video here. So I'm working on the stromal side.
And Dr. John, we have 4 minutes left.
Yes, ma'am. This is the last video, ma'am.
Yeah.
So stain with the trypan blue. And what good thing is that scored by the forceps. This is my almost, very early videos of DEMEC, almost 3 years back. Once it has been done, partial segregation, simply by the customized forceps, we can peel it. We should not stop it while we're pulling there. Almost more than central part, we have to pull. And let it be, and we can make a dermal punch there, and it float it back. And from the stromal side, we make a S mark. Excuse me. Then followed then partial definition at the desirable amount of the graph, which is approximately 7 mm. And we can see the peel easily peel off. And we put it in the petri dish, which is within the basis solution. And again, we stain it before the moving to the petri dish. And the second part is the it's rolled. The endothelial side is just like the folding, like this only. And we keep it in the injector. Then we move on to the insertion. Once we insert it in the hair, we should keep in mind the the anterior chamber should be hypotonous. Eye should be hypotonous. It should be flat. And once it is inserted, we should be suture first. Otherwise, you may lose your graft. And by the dabbing, we just unfold it. The endothelial cell sides are scrolled upwards. So by dab it, we complete the thing. And yeah, should be given just like the dissect and suggest complete uneventfully. So these are the post-operative pictures of this patient. We can do the facodissy, ultrathin facodissy of the first picture. We can see the patient had already having the FED Fuchs endodystrophy in the both eye. The first eye we have done the dissect of the facodissy. The other eye we have the demic, and both have 6/9 vision. So you whatever the surgery you do, the outcome is that if you do appropriately, probably the early gain in the demic is that is a good advantage, as erection is less and the visual quality is much better in the demic as compared to the dissect. But if you do the ultrathin dissect, equally it is can be comparable down the line with the demic surgery. So these are the what are the new things are there. There is ultrathin dissect when the graft thickness is less than your 15 to 100. It is between the 50-99 micron. That is called ultrathin dissect. So here that the outcome will be the comparable to the dissect surgery. So these are the ultrathin dissect. I'm just showing one of the surgery of the ultrathin dissect. I'm the first forward the surgery here. We do the first lamellar dissection here. And this is the Desmond speed you can do the thing by the lamellar dissection. We cut the first one with approximately 400 micron, followed by a customized crescent was used, which is approximately 90 micron by the Joda surgical. I have no financial interest. And second round of dissection is done there. And the after the second round of dissection, it became very much thinner. we are inserted because graft is folded like a scrolled up like a demi graft, and we trying to unfold it, and you can see how transparent graft is during the on table also, and the surgery is completed. And these are the outcome of the patient. The one-eyed patient who underwent the demic surgery, ultra-thin dissect, and you can see even one-eyed patient, this lady patient having the 6/9 vision plane, or one patient another 6/12 vision. So ultra-thin dissect also the new outcome. I mean that this is the patient having the new thing you can add it in your practice, and you should keep in mind that that is a good comparable with the demic too also. So these are the outcomes. I'm not going in details of these things. So what is the post-op medication? What are the medications? In post-op, immediately we should start giving the topical antibiotics. Topical steroid, mainly the prednisolone acid 1% is given in a tapering fashion, but it has to be tapered very slowly over the months, at least minimum first, and without monitoring the IOP. It should be very tapered and even maintain the therapy for at least once in a day for at least more than 6 months to 1 year, and then move on to the softer steroids like loteprednol, and then we can taper it after the couple of years. And it should be
Dr. John,
whenever.
can you
Yes,
please
ma'am.
wrap
Yeah.
up in like
Yes,
a
ma'am.
minute?
Yes, ma'am. And the
Yes.
suture,
Thank
we
you.
should not cut the suture before the 6 months because we lose the technical stability. Meanwhile, if the loose suture is there, we have to cut the suture or replace the suture. And once we do the keratoplasty, the resident should be keep in mind it may face some of the patient who come with the drop of the vision with these clinical features, graft edema and KPs, and that has to be keep in mind that you may be dealing with the graft rejection. So it has to be addressed properly. So you can give the intravenous 500 milligram single dose of ibimanital, methylprednisolone, or you can with tapering dose of the oral steroid, or you can immediately refer the patient to the cornea specialist, but you should not be treating this patient just like a conjunctivitis giving only the antibiotics. So that has to be keep in mind that there chance of rejection too also. So what are the outcome? Outcome in the means of the BCVA, surface question, cornea clarity, and happiness question of the patient. So my tech clinic messages are that penetrating keratoplasty is a safe and easiest surgery to address the corneal blindness. DELC is a surgery of choice with stromal pathology with functional endothelium. Endothelial keratoplasty provides the significant safety and the functional advantage over the PK eyes with the endothelial dysfunction. They make orthopedic or the femtosecond laser assisted surgery are the upcoming technique. Need a proper surgical training and the dedication for the cornea and the team follow-up and dedication for the and the treatment for the rejection. Keynote for clear functional graft. Manual dissection of the dissect is the least expensive and maybe the more appropriate procedure in the Indian scenario, where we can only need for investment for the microkeratum or the pre-cut tissue. So these are the question at the patient who came to our OPD, and these are the smiley eyes after the transplantation. So there, here the rise the what is success of the cornea. Why should we know the cornea transplantation? Thank you very much. Thanks for your patience sharing. I try to cover almost all surgical procedure. May not resident in your places, you may not be able to see sometimes. So these are the outcome for those eyes which is came with like this, and this is the outcome of this thing. Different all the modalities of keratoplasty here we are showing here. Thank you very much. Thanks for the AIVs and all the mentors for giving me the opportunity here. Thank you very much. And we are in CSI, we are conducting the every year the corneal, the all modes of corneal the science on training. So if you someone is interested, they can enlist in the CSI course too also or short term here. Thank you very much.
Thank you, Dr. John. You may stop the screen share. In keeping in view the time, a quick comment from Dr. Rama and then Dr. Merle.
So a couple of quick points. That was a very exhaustive presentation, John. So I think one is the emphasis on the white to white. I think when you're examining the patient, it's very important to do a cursory examination of the white to white, because if the eye is a little small and you put a large graft, you're going to have compression issues. Second is to highlight the role of Fleringer's ring. I think for the beginners, definitely, especially if you're going to violate the lens iris diaphragm, or in pediatric cases, definitely do consider Fleringer's ring, because in pediatric cases, you'll have a lot of scleral collapse. It may be worthwhile considering a Fleringer's ring. And if there is a bleb, you may want to decenter it. The third thing is about sizing in keratoconus. I think in keratoconus, always look at where your cone is, and this don't blindly go by what you're seeing on table. It's important that you mark it at the time of the slit lamp examination, and you may want to consider 0.25 sizing, maybe because you want to counter the myopia. The fourth thing is about the DMEC donor selection. I think it's very important that you select graft from between ages of 45 to 70, because here is where you get the correct scroll in terms of elasticity and in terms of the thickness of the scroll. That's it from my side.
I just share for 1 minute, ma'am.
Yeah.
Almost.
Yeah.
Yeah, when I was
Yeah,
a PG,
please.
ma'am, when I was a PG, so that time actually the center where I was done my PG, though there was no, I mean that time DESEC has been come. I'm talking about 2011. So during the fourth paper was that everybody was learning for the DESEC. The term is very unknown to us that what is the TACO. So I was asking everyone what's the TACO, and even that time we also not that much active. We search for the TACO video. So some of my friends say TACO means only fold, and keep in mind blindly just digest it and just vomit it like that. So it is that is actually good platform for the AIOS. That is those who are not exposed to that is any sort of the transplantation. At least they should know the things what surgical we are doing in different modes of surgery. That is actually the beauty of this course. Thank you very much.
Thank you, sir. And may I also request Dr. Moral ma'am to give her inputs? And ma'am, what would be your 5 pointers that would be most important for the residents?
Yeah. So I think one of the important things is case selection. It's important to know what kind of patient you're dealing with, what is the best tool to understand what type of surgery to do in that particular patient. And essentially, if you have access to an ASOCT, it will help you, in differentiating whether there is scarring, whether there is edema, and how to choose the type of laminar surgery based on that. And I think the other thing would be, mastering your surgical technique, because the way you handle the tissue is very important. When we're doing a full thickness graft, the tissue handling has to be very gentle. We should not lose endothelial cells. When we're handling a DMEC scroll, we have to know the proper technique of unfolding a scroll. I think handling a tissue is very important. And the other thing that we need to know, of course, is the post-operative management in order to keep those grafts clear. Because if you're not able to understand what is happening with that graft, and you miss the early signs of rejection, then you lose the whole game. I think just 4 points are enough.
That's absolutely helpful, ma'am. Thank you so much. And now may I request Dr. Abhishek sir to please go ahead with his talk on aphakic management. Over to you, sir.
Yeah, good evening everyone. Are my slides visible and am I audible?
Yes, sir, your slides are visible, sir.
Am I audible also?
Yes, sir. All good, sir.
Okay. So thanks AIOS for this opportunity and all the cornea experts here, because I am the only retina and they have educated me very well for questioning my residents in any cornea case now. So my presentation is unlike any routine aphakia presentation, would also include how we can do some low cost innovations which are practical, and how we can develop some research questions also. So coming on to diagnosis of aphakia, which is absence of crystalline lens, and there are various causes, and most common being trauma and cataract surgery, and few are congenital cases also. So this table I believe every resident would have seen in our basic book, that is the Parsons. So spectacles, they, because of high power, they cause magnification, and various distortions because of pin cushion and jack in the box phenomena. So contact lenses are also not very practical because of daily schedule for their cleaning and maintenance. So universally acceptable are the intraocular lenses for management of aphakia. So whenever we have the capsular support, so we prefer a 3-piece sulcus lens, and otherwise it could be other options where we do not have a sulcus. So these options would be a ACIOL or a iris crawl lens, or various techniques of scleral fixation, which could be a sutured and non-sutured ones. So ACIOLs, the main long-term problem is risk of endothelial damage, and the stability wise, the sutured ones, though it is high, but that is slightly lesser than the glued ones, which are directly fixed onto the sclera. So we have always been taught that prevention is better than cure. So for beginning resident surgeon, it is very important to plan each and every case, and we should be virtually doing our surgery even before we enter the OR. Once I had a chance to visit a center wherein trainee fighter pilots are trained. So I saw that in front of everybody's study table was an instrument panel of the fighter aircraft, and they were supposed to practice at least 1 hour every night before they go to sleep about the mission and the sortie next day. So that actually that mental surgery would help them in planning the whole case next day. And we should remember that each step is important and it is interlinked. So whenever aphakia, the precursor of aphakia is the PC rent. So early recognition is very important, and correct use of our optical instruments, that is the microscope, knowing about the microscope, the settings, about the retro glow if it is possible, and picking up those small clues during the hydro or during the phaco itself about the fallibility, about the pupillary snap, about deepening of anterior chamber would avoid this complication. So whenever there is a PCR, you have to freeze your movements, reassess the situation, and then proceed forward. Because unless and until you have good capsular support, the IOL is not going to remain stable the next post-op day. So before going on to the actual patients, because now all the mentors, they would be realizing in setup like ours now increasingly it is becoming more difficult to immediately giving surgical exposure to residents without doing a wet lab or without doing a simulator exercises. So wherever they are available, they should be explored, and various bodies like AIOS, they also have these training sessions, so they should be fully utilized, and also the ICO competency based rubrics, they should also be utilized so that the patient is not harmed. So I'll just take you through some of these simpler cases wherein this is a 33-year-old lady. So the IOL is there, but practically this is aphakia because she has diplopia, she has blurred vision. The cataract surgery was done 5 years back, and now she has these complaints. So I just took this patient, enlarged his posterior capsular rent, which you see the margins are well fibrosed now, and just did the posterior capsular capture of this IOL, and next day her vision was absolutely fine. So whenever you have an intact sulcus, your anterior vitrectomy can address the pathology, and you do not have a residual vitreous traction, and the lens can be implanted safely. But we should always remember that even if the sulcus is intact everywhere other than the inferior maybe 4 to 5 clock hours, you should you should reconfirm whether the IOL would remain stable or not, because over a period of time the gravity would show its magic and slowly the IOL would sink in. So this is another lady who has got this zonular dialysis of 3 clock hours, and she was planned for routine surgery elsewhere, wherein a CTR was implanted and a lens in the bag was also implanted. But after 3 to 4 weeks, the IOL used to crawl up, and though the bag was very well centered, so the surgeon refixed it twice. The possibilities, we thought that it could be the white is white, but that was not the case. It was actually the fibrosis of the capsule which was pulling this CTR because of asymmetrical forces. So when I took up this patient, you can see that there is inferior gap, though the bag is well centered. So in this case, I created opening in the posterior capsule, and as the IOL every time was shifting upwards, so I just captured that optic in the same bag, because the bag with CTR complex appeared very stable. And this is the post-op. You can see the IOL is well centered in this pseudophakic eye. So these cases are very notorious. So this is a posterior polar cataract, where in initial part of our surgical career we should not choose these cases, because otherwise we would land up in either in a nucleus drop or in aphakia in most of the cases. So this is the intra-op OCT, which is actually showing that there is a plaque, and maybe the capsule either is very thin or it is absent in that area. So as we proceed with the surgery, we avoid hydrodissection in such cases. And then during the surgery also, because I had my IOCT with the microscope, so throughout the case I was just curious that what happens and whether this plaque remains stable or the capsule opens. So far so good. There is a small residual plaque there, but the capsule, though it appears very thin, but appears intact. And as I polish this capsule under controlled conditions, that weak area that opens up. So as I said, in this situation there is no need to panic. Your assistant should give you Helon, and it should go from the side port, so that you stabilize those forces in the anterior chamber and reassess the situation, that what is the next course of action, and then you can proceed. So keeping calm, I again reassessed how big is the opening and what should I do next for this patient. So this is the IOCT clearly showing now this defect. So the safest option I thought would be to put a 3-piece lens, and this is the end of the case. So this is another resident case who was doing the stop and chop technique, and most of the matter was out, but he did not realize during initial part of the surgery, but later on some of the matter that dropped down. So the patient was taken for a pars plana vitrectomy along with the lensectomy, and this matter was taken out from the port itself, and but there was no capsular support enough to keep the IOL stable. So in this case we did glued IOL, which I'll show you. These are some of my modifications, where I use a lamellar scleral tunnel and a vicryl loop, so that you do not require assistant, and then in this case we use laser to flange this. And this is day 1 post-op, wherein you can see by this technique these IOLs are well centered. So some of these cases a primary surgeon can handle, but we should never mix ego and vitreous, because otherwise the complications are disastrous for the patient. So we should refer all those patients who have lens drop, IOL drop. Sometimes it is very tempting that the IOL is dangling behind the iris and we try to pull it, but that causes immense amount of traction at the vitreous base, which may lead to retinal detachment in later situations. And if we are not able to address all sight-threatening complications, then these patients should be referred. So this is not a very happy sight when you see during the surgery. So another patient operated elsewhere. This glow tells that there is a nucleus or cortical matter inside. So I plan to do a PPL. So this after finishing vitrectomy, you can see the nucleus appears slightly hard. So I switched on to the phacophlegmatome, which residents should know that it is just like a phaco tip only, which is longer without a sleeve, and the fluid that comes through the infusion port. But before doing this, the vitreous should be removed, because otherwise it causes traction on the retina in the periphery. So this patient, after the lens fragments have been removed, I assess the situation of the sulcus, and there is some ray of hope. Inferiorly the sulcus is intact, and then a 3-piece IOL is dialed into the sulcus. So depending on various situations, we have various options like ACIOL or iris claw lenses. They are again coming into fashion, or various other options. So ACIOL I think is very less in use now, but it requires a deep AC, and certain subset of patients, elderly, where you require a quick surgery, maybe some preference could be there. I do not have very vast experience with AC IOLs, and neither with iris claw lenses, because in my initial career only I saw 2-3 iris claw lenses which were dropped, so I could never develop a confidence in these lenses. So now, like everything is cut and paste, so sutured SF IOLs are also slowly phasing out, and the main problem with them is the time taken, all those complexities of the suture, and on a long-term stability point of view also there is suture erosion and lens dislocation. So then came Dr. Amar Agarwal's technique of glued IOL. So this avoids all the hassles of suture, and you can use foldable lenses, so you have smaller incisions, but there is lack of long-term follow-up. However, now it is almost 10 years plus, and for the beginning surgeons, the most challenging steps are handling the trailing haptic and tucking the haptic in the conventional technique. These are the various needles, forceps and glues required. So the surgical steps of a traditional glued IOL are straightforward, wherein you have to mark the cornea so that you make the scleral flaps there, and then you can go ahead with the combined procedure if you need to do, and then implantation of the lens and fixation. However, before planning, you have to look for any scars at the planned incision site, because most of these patients would be either post-trauma or post-surgery. It's very important to look for pupillary abnormalities, because if you have large pupil, sphincteric tears, or aniridia, or iris is absent in a particular quadrant, then after putting the IOL, this diplopia is going to worsen and patient may have glare. Also, I'll show you a case wherein even you can use capsular remnants as your artificial iris, so that at least the light is blocked in that area. So do not just strip off anything you see in that capsular area. And always in the beginning you should have an additional IOL which is standby, because the haptics of this 3-piece lens are made up of PMMA, and they may break with unnecessary manipulation in the beginning. Plus some other situations, look for white to white and amblyopia management post-op. So this is a video slightly old now, during my fellowship days, wherein the 180 degree is marked, and then 2 scleral flaps are fashioned so that the haptics which are exteriorized, they will be under these flaps. And so the only important precaution here when you are dissecting these flaps is do not hold them with any forceps, otherwise you could have amputation of these flaps, and then later on there will be issue with the haptic exteriorization. This is the 23 gauge needle which is being used, and this is a case with the dropped IOL. So we immediately look for it. The retina surgeon would be very happy if she sees that it is a 3-piece IOL, and the same IOL we would like to fix, because then you have to just lift this IOL and take out the haptics. And this is very important. That's why I said if the IOL is stuck somewhere in the vitreous base and you pull it, then you are going to create lot of retina problems. The IOL is picked up, and then the haptics are exteriorized, and this can be done either with the help of needles or your various microsurgical forceps which you have. Similarly, the haptic comes outside from the other end also, and then it can be fixed. So some of the complications with this traditional technique would be haptic breakage, hypotony, vitreous hemorrhage in most of the cases, but it clears, not most of the cases, but the clearance would be in most of the cases. Sometimes there could be hyphema, CME, and pupillary capture. So this pupillary capture, initially we used to see in at least 20 to 30% of the patients, but later on we found that if you do a peripheral iodectomy in low cutter settings, then there is no pupillary problems in these patients. So as I said that during my fellowship days, when I started doing these glued IOLs, I used to keep a very, very strict record of most of follow-ups. So we published this in IGO, and I compared this with my consultant, that what is the difference in the outcome. So except the time, I took more than the consultant, but otherwise the complications and outcome wise was comparable. So after this era of glued IOLs came Dr. Shin Yamane, his flanged intraocular technique, wherein he used to went inside transconjunctival, pulled out the haptics of the IOL, and then the ends were flanged so that they are not able to be retracted. So he traditionally uses these cauteries, but this was a recent editorial wherein this flange exposure and risk of endophthalmitis has been pointed. So we did couple of cases with traditional techniques and then Shin Yamane's technique, but then later on we also found out the problem of flange exposure, because you are going through the conjunctiva and sometimes they remain subconjunctival, and also this fibrin glue, we found that in our modification that was actually not required. So we described this new technique which has been published in IGO, and this is now widely what we practice and teach. So here you mark 180 degree. That mark is very, very important. That is going to decide how well your IOL would be centered and how much astigmatism you will give to the patient after the surgery, because if all these markings are not correct, then slight lens tilt would translate into much higher astigmatism. I'll show in the video that you make lamellar scleral tunnels here, and then with the help of a needle you exteriorize the haptics of this IOL, and then the autologous blood can be used, because here the IOL is on its own, is stable on the sclera, and just you need to close the conjunctiva. So this is the video. You have marked 180 degrees here, and then this marking of 2 millimeters each size is important. And here you make a scleral tunnel, and this is the AC maintainer, which is a vitrectomy trocar which we use. And if there is any retinal procedure to be done, that can be completed. Now through that lamellar tunnel is my needle which is going. So I'm not going transconjunctival. I know exactly the point where I have to make the entry, and this IOL I have injected and put the haptic on the iris, and then it can be pulled out, and then your and the flange can be made. This is the heat cautery, traditional one with the which is a ball cautery, and then similarly it can be pulled out from the other side also, and the end is just flange. So if you see here, the flange here is covered, very well covered with the lamellar scleral tunnel, and on top of that is this conjunctiva, which in most of the cases, if you use autologous blood and wait for some time and patient is not on antiplatelets or anticoagulants, this sticks on its own. So this was accepted at various fora. So now we did a further modification to this technique, wherein we, as you saw earlier, that we made scleral pockets and used autologous blood. But one problem we were facing was that sometimes the needle which you are using, though the classically described is your 30 gauge needle, but 30 gauge needle that has got a different lumen which was used by Dr. Shin Yamane, that I don't think is available in India. So as like the previous we made these scleral tunnels, and then we have used these two ties of this proline, which will be coming on to the haptics here. We'll straightway go to the video. Here these are the lamellar tunnels I am fashioning, and this is the AC maintainer. And see, now these two ties, they are actually, when the haptic comes out, I have something which is which will secure these haptics, and same knot would be used to give it additional layer of safety apart from the flange when it is in the scleral tunnel. So this suture is tightened, and this is already flanged also. So because we are using a thicker needle, the chances of the haptic migrating inside are almost nil. So the haptics, they are buried inside this lamellar tunnel, and that closes like a SICS tunnel when the IOP builds up. So you do not require anything, any glue or any suture or any channel here. You just need to put this conjunctiva back. You can even use a cautery or autologous blood or even fibrin glue in some cases. So this is the outcome. This is the first day post-op. You can look at the conjunctiva, it's absolutely closed, and the outcomes are fantastic in these patients. So we published the results of this technique. This is and we did a shim lung imaging. So actually the tilt and the outcome is comparable to phacoemulsification as published in the literature. So you can use various methods to flange the ends of the IOL. Here you can use a laser or even cautery or thermal devices you can use. So sometimes there still could be flange exposure. Recently I saw this lady, and here she is coming with foreign body sensation and all those symptoms. So this lady, I just did a thermal laser to this ends under topical anesthesia, and the bulb which was larger, that has actually reduced in size. So sometimes we have to innovate. If you see this our brave fighter pilot who with a MiG-21, actually he shot at this F-16. So in certain situations of resource constraint, when we are, sometimes if you do not have a sulcus and if you do not have any other specialized IOL, so even you can fix a normal rigid lens with eyelets with the Prolene. Here if you see the Prolene suture is exteriorized with the help of the needle, and then other end of the haptic goes through the eyelet which is there. So you could either use a normal lens or a SFIOL where you do not want to put the sutures and knots. So this is a double flange technique which can be followed, and in those situations in elderly it can be used. So as I told that all the remnants of the iris should not be removed. This, if you see, is a patient post trauma. He has aniridia and intense glare but diminution of vision because of this cataract. So now he is planned either for either you put an aniridia IOL in him, but in that case astigmatism and all those complications are there. So we thought that we will do a pars plana lensectomy, a glued IOL, and I intended to leave this capsule as far as possible so that it blocks those peripheral light. So this is my IOCT actually confirming that the capsule is absent in that situation. So this is a 25 gauge combined with 23, and here after the lensectomy is done. So I want to leave this capsular remnant here so that the light is blocked. Same with the similar technique, making those flanges. And from this side also, as I shown you, these Prolene loops, and immediately you see the IOL is very well centered, and even you can look for the entries which you have made, whether they are, and this patient was actually 6'9" next day, and there was no glare practically. So certain newer trends, the IOLs have a limitation that only that particular model.
We need to wind up in 4 to 5 minutes.
Yes, madam. I'll take hardly 30 seconds now. So my the only that particular model of IOL can be implanted, and sometimes we want to replace the lens. It becomes difficult, and nowadays the patient is becoming more and more demanding. So premium IOLs cannot be used in those situations. So now there is a research is already going on, and there are a few publications which I came across were about implantable devices, like this one is a VAMA device, wherein you anchor the capsule in place with the help of these sutures, and then the lens can be implanted. So to conclude, we have multiple options available for management of aphakia, but we have to understand that all these techniques are still evolving. So there is no perfect technique which will have universal applicability, and we should always adopt the technique depending on condition of the eye, like the associated ocular features, and most important is the pupil size, iris defects, and aniridia, conjunctival scarring, scleral thinning or staphyloma, because wherever we are making these scleral entries we have to make sure. And also in some of the patients I have seen wide to wide diameter. I remember one of the patients where we had to fix the intraocular lens. First a horizontal glue dial was done, but that got subluxated because one of the haptics used to go inside the eye, and then again three times at least this was done, and then finally we did a vertical glue dial, and that is still remains stable, and of course surgeons expertise. Thank you very much. Yeah, I finished now.
Thank you so much, sir. Thank you so much. So we just are in the process of just quick final comments from Merle. I think she does a lot of scleral fixated IOLs. And Merle, would you like to comment on the techniques? So it was an amazing presentation, and I think a very daring for a corneal surgeon to watch even.
Thank you.
Yeah. So and very exclusive and very nice videos, and the technique that you have devised is amazing, which should be learned by a lot of people.
Yeah, and that is very straightforward technique also, ma'am. Nothing here.
Yeah, so I don't know. I think with the retinal surgeons doing glue dials, I think we've taken a step back and we don't do the SFIOs much. So I think what we used to follow initially was kind of the 4-point fixation with tensile proline. Then we realized that years down the line that's going to drop somewhere, and then switch to kind of using Gore-Tex and 90. So I think that helps, but still glue dials definitely will give the patient an added safety, and so I think there's not much to comment about us doing those anymore.
Yeah. So may you please stop sharing option, Dr.
Yeah,
Desh?
sure.
Dr. Rama.
Yeah,
any
so I
comment?
think we are also doing less of these SFIOs because the retina surgeons are doing a lot of it. But what we used to find is that is not good enough because you have peripheral tag from the vitreous, and then these patients, especially when you're combining with other procedures like PK, otherwise there used to be a lot of CME in these eyes. So that was one limitation. The second thing I think is that if from an anterior segment perspective, if somebody comes to me with an aphakia, so I think there are a few things from the resident's perspective I would like them to focus on. Number one, you have to understand why the eye was left aphakic in the first place, because if you are the primary surgeon, you have an idea, but if you're not, you have to get a good history about whether there was trauma, what was the reason for the cataract, number one. The second thing, the emphasis on white to white has already been described. The third thing I think is important also to look at the keratometry, because you may be all along addressing the lens issues, but you will forget that because of tight suturing, you will have significant astigmatism and patient will become an unhappy patient later on. So if there are tight sutures after the aphakia, the primary surgeon has sutured the wound, please pay attention to the keratometry values, because sometimes you want to release the sutures or do something about it. And visual potential is very important because you'll be seeing these patients after several years, and if you look at them, they may have a small exotropia, or they may have other reasons like amblyopia was mentioned, because of which the eye is not seeing to its fullest visual potential. A simple test like potential acuity meter or even a contact lens trial will tell you what is the extent of visual recovery that you expect in these eyes. And sometimes I like to consider specular microscopy, especially if I feel the cornea is really borderline, because sometimes what happens is there's a lot of iridodonosis that's been happening over the years. These eyes would have had some inflammation in the initial period or glaucoma, so they have a borderline endothelial compromise, which is not very clinically, which is very subtle clinically. So it may be a good idea to consider specular microscopy. And if you're planning, if you have a peripheral skirt of capsule in a patient who's been left aphakic several years ago, UBM may be a good guide to tell us whether you'll be able to still place it in the sulcus or not.
Yes, very nice points. And yeah.
Ma'am,
Yeah.
being an endoscopy surgeon, can you recommend the Irish claw lens, because technique is much easier? Because I have done couple of cases. Most of the cases, whenever we do the ABK or the PBK, even sometimes the PCA will place in the AC, and that was the reason for the decompensation. So So once we open the eye or even then we surprise the things, maybe it's full of vitreous. We have to do the intravitrectomy, remove this, I mean the PCL from the AC, and probably we not ever sure about the sulcus due to that time. Do you reckon because it's technically much easier Irish claw insertion, and I have done couple of cases, and for the even also longest follow up for more than at least 3 to 4 years. I mean, they're maintained good also. Though the only things are that post-operatively we can't do the dilated fundus examination because we can't do we can't see the peripheral part of the fundus, but the central part if we maintain the things. And what's your opinion, suggestion, sir? Being a cornea surgeon,
Yeah, asking me, sir.
do you prefer the Irish claw lens?
Because the thing is that my aim before implanting the lens is to address, all those pathologies, whatever vitreous traction. Because I remember during my residency once I have seen a video by American Academy wherein those sponge vitrectomy, they have a beautiful demonstration wherever we are doing a sponge vitrectomy, and the kind of traction it is causing at the vitreous base. So plus regarding these iris fixated lens, which I feel that while we are doing any surgery, we are trying to at least restore the normalcy or the something hanging on to the iris. And plus I have seen 2-3 cases initially only with the drop of these iris claw lenses, so I am not very fond of, and I do not have much practical experience also, sir. But if it is safe and patients are doing fine, then it is ultimately the surgeon's call that maybe a more experienced person can add on.
Okay. Thank you so much. With this, we come to an end of the 6th episode of Guru Sangam on cornea. I want to thank all the speakers, Dr. Avdesh, Dr. John Sarkar, Dr. Sarita Agarwal, Dr. Kalavini, and Dr. Taran Sood, and our expert panel of Merle and Dr. Rama, who stayed with us till the end. So thank you so much, everyone. I hope it was an interesting session for everybody. Thank you once again.
Thank you.
Thank you. Thanks a lot.
Thanks a lot, ma'am.
Thank you, ma'am. Thank
Thank
you.
you.
Thanks to all
Thanks,
senior
everybody.
mentors. Thank you very
Yeah,
much.
it was a nice
Thank you.
session.